through the implementation of a robust electronic training and development module called Relias. The Relias platform provides specialized information for clinical and non-clinical healthcare disciplines and allows employees to learn independently. There are over 2,000 course offerings ranging from soft skills such as software programs and management skills to clinical competencies such as medication safety and lactation consultant training. The education provided is utilized by staff to ensure they are kept abreast of standards in accordance with our current regulatory requirements. It is also noteworthy to mention that Relias offers classes that provide credit for nurse licensure renewal. Since its November 2020 implementation, 508 employees have completed mandatory annual training courses through Relias, and 126 employees have completed additional courses, totaling approximately 3,000 training hours. Our HR and nursing education team collaborate to facilitate the assignment and delivery of courses. SRMC's Educational Institute is staffed by 2 full-time registered nurses, Sarah Colorosi and Maya Smith. Both nurse educators are certified instructors, which is a significant cost benefit in training and education for the organization. For FY 2021, the Educational Institute has also been engaged in delivering training sessions to support staff development. To this end, during FY 2021, 7 patient care technicians, or PCTs, have completed the national certification course to become certified telemetry technicians, and 58 staff nurses and nurse leaders participated in the Charge Nurse Development Program. The Institute provides education on new policies and procedures to ensure compliance with the Joint Commission. It facilitates mock codes to support staff readiness and train on best practices given the new standards related to the global pandemic. Additionally, in-house certification training is provided to employees on crisis prevention intervention and basic life support, which is an efficient use of time and resources, particularly since these certifications are a requirement for most clinical providers. The ability to provide these certifications results in an annual cost savings of approximately $45,000. Capital. SRMC recently restarted its capital committee, which is being led by Mr. LaRue Brown, Director of Procurement, and Attorney Tina Commission, Chief Compliance Officer and Legal Counsel, to address this vital component of our operating expenses. Currently, SRMC lacks the capital funding needed to keep pace with improvements and upgrades in technology and to address our aging plant and infrastructure needs. Each year, SRMC must defer capital improvements or use operating funds to meet emergency capital needs. Unlike other similarly positioned hospitals, SRMC does not yet have the ability to set aside funds for regular capital improvements. It is not strategic for us to address capital needs at the time when they become critical or urgent. We are charged high or premium rates when we have to make quick, unplanned repairs. Our inability to plan for and fund routine capital expenses will continue to affect our operating costs. The average age of the physical plant at SRMC is 26 years, whereas the age should be closer to 10 years with proper funding of depreciation. I would like to take this moment to recognize our biomedical engineering team, especially Mr. Peter John Baptiste, SRMC's Director of Technology Services. Because of his experience, education, and extensive training in equipment maintenance, SRMC is less reliant on vendors for medical equipment repair and maintenance. This has resulted in a significant cost savings to the organization. Contracts. SRMC engages external vendors through contracts and agreements to support our essential operations. Some examples of our current contractual arrangements include revenue cycle support with Craneware and Medical Data Systems, temporary physician and nursing staffing through agencies such as Global Medical Staffing and Professional Nursing Services, respectively, interpretation and translation services through Language Line Solutions, clinical equipment and clinical supplies with Abbott Laboratories, and IT support with Meditech. Over the past year, SRMC's contract committee has worked diligently to review, recompete, and renew contracts and agreements to ensure we are receiving the best possible terms available in the market. SRMC currently has 98 active contracts, 38 of which are fee-for-service. Of those 98 contracts, 63 are still in their initial term or have been recently renegotiated. 14 are currently being developed or revised with new terms, and 4 are being discontinued or terminated, while 17 remain in the queue to be renewed this year. Accounts payable. In FY 2017, SRMC had an accounts payable totaling $43 million. At that time, we could barely cover the costs of our employer payroll withholdings. However, through funding received from our Medicare and Medicaid reimbursements and improved cash flow, SRMC has reduced its massive vendor debt by $29.2 million. Today, our accounts payable is down to $13.3 million. I would also like to highlight, as an extraordinary testament of our financial stewardship, SRMC's payment to the IRS, GERS, and WAPA are all current. Information technology. Our budget presentation last year centered on our need to fund our technology and equipment upgrades, specifically the Meditech Expanse, which is an electronic health record software at the cost of $3.4 million, as well as Omnicell, an automated dispensing cabinet system, at the cost of $2.7 million. However, realizing that the cost to upgrade to Meditech Expanse is currently prohibitive, our immediate objective is to optimize our existing IT infrastructure so when funding becomes to acquire Meditech Expanse will be seamless. We remain invested in improving our information technology capabilities to provide better care for patients. Healthcare IT support increased patient safety, decreased medical errors, and strengthens the interaction between patients and healthcare providers. We are also exploring telehealth opportunities to better serve patients in this new virtual environment. We have applied for several grants to support these telehealth ventures. Facilities. Facilities expenses are a huge part of a healthcare system's financial health. Estimates have been made that a healthcare facility's annual budget can range up to 10% of the total cost of the organization. This would allow for timely and appropriate preventative maintenance, repairs, and replacement of the facility's capital, which has met its useful life. As we are aware, our territory's healthcare facilities were severely damaged by the storms in 2017. While our hospital has yet to undergo any permanent repair or renovations from the impact of those storms, we have made necessary temporary repairs to maintain a clean, safe, and quality healthcare environment for our patients and staff. Unfortunately, those temporary repairs were supported through our operational funds, as there is no longer any federal funding available to repair continued damages left from the storm. COVID response. A large portion of our facility's budget has been utilized in our successful response to the COVID-19 pandemic. SRMC successfully designed and engineered mechanical ventilation systems within various units of the Roy Lester Schneider Hospital and the interim Myra Keaton Smith Community Health Center for the sole purpose of creating negative pressure environments to safely care for our patients and ensure safety for our medical and ancillary staff. In total, we have created patient care areas capable of accommodating 100 patients safely in a negative pressure environment. Additional feats accomplished by SRMC to include Myra Keaton Smith Community Health Center include our COVID response, in our COVID response include constructing 2 exterior structures at each location to safely triage patients exhibiting COVID-19 symptoms prior to entering the main hospital or clinic. Successfully converting our fast-track area of the emergency room to a respiratory COVID negative pressure observation and triage unit. Increased our surge capacity within the facility by adding 2 50-bed inpatient units. Purchase 83 critical care hospital beds for surge capacity. And purchase and install 40 critical care central monitoring systems and 25 ventilators. I would like to thank our entire staff for the sacrifices you have made to continue working throughout this pandemic to ensure the safety and well-being of our patients. I would also like to thank our COVID task force for the ongoing work you are doing in response to the pandemic. I especially thank our infectious disease specialist and DOH medical director, Dr. Ty Hunt Caesar, infectious control coordinator, Ms. Dawn Grell Joseph, and employee health nurse, Ms. Bernice Wade, for your hard work and ongoing commitment to combating the effects of the COVID pandemic. Oxygen generator. One of the most important accomplishments that SRMC is proud to discuss is our procurement, installment, and implementation of the new oxygen generator. Not only does this equipment give us the ability to become self-sustaining as it relates to producing our own oxygen, but it also reduces our reliance on offshore vendors to supply us with liquid oxygen. The implementation creates huge cost savings for the organization to the tune of approximately $800,000 a year. Having the ability to efficiently produce our own oxygen is also a key and critical element in combating the pandemic and a major relief for emergency preparedness as we enter the height of this year's hurricane season. We completed the construction of the oxygen generator housing in December 2020 and completed the installation of the oxygen generator system in June 2021. The system is now scheduled for certification and is set to be operational within this coming week, at which time we will begin to produce medical-grade oxygen for the entire hospital. Once fully operational, we will begin the process of weaning ourselves from the dependency of liquid oxygen, which has always been delivered monthly from the mainland. This is indeed a significant accomplishment for our organization. As a public hospital, we are required to provide certain services to meet the healthcare needs of our community, regardless of their profitability or impact on our resources. In hemodialysis, our dialysis care unit continues to see annual budget shortfalls. This is due to the extraordinary cost of supplies and shipping and our lack of ability to take advantage of economies of scale. These challenges will continue to put an economic strain on our organization and ultimately on government subsidies. Despite the enormous financial challenges to maintain our dialysis program, The Schneider Regional Medical Centers continue to offer quality renal replacement therapy or dialysis services to our St. Thomas and St. John patients with end-stage kidney failure. Our current hemodialysis patient census is 68. The department is manned by an excellent team of nephrologists, nurses, biomedical, and dialysis technicians. In February 2021, hemodialysis administrator Ms. Vanessa Hodge and her excellent team of dialysis professionals successfully achieved CMS recertification and have demonstrated improvements in national benchmarks set by CMS. We are collaborating with other dialysis facilities to entertain solutions for overall renal replacement therapy in the territory. In our emergency room, SRMC recognizes that one of our greatest challenges is our emergency room. It is the area where we engage most of our clients. Our emergency department saw up to 20,000 visits a year prior to the pandemic. It is a significant bottleneck regarding patient flow, and we understand the need to continue to optimize all its ER processes to create improved patient satisfaction. We have recently deployed a team from multiple disciplines to focus just on these emergency department improvements. Emergency room volumes. As illustrated, SRMC's emergency department volumes have decreased by 19% in 2020 when compared to 2019. Based on the current average ED visits of 1,457 per month, it is anticipated that our ED volumes will increase by 33% in 2021 when compared to 2020. Emergency room triage and discharge times. Over the past year, SRMC triage wait times decreased by 21% compared to the previous year. The arrival to departure times also decreased by 12% since 2019. The current benchmarks for ER triage wait times and arrival to departure times are 30 minutes and 247 minutes, respectively. SRMC's current average triage wait time is 30 minutes. SRMC continues to monitor our ER wait times with the goal of sustaining improvement and maintaining national benchmarks. Quality and performance improvement. There is a direct correlation between solid financial performance and quality patient care. Findings have suggested that financially stable hospitals are better able to maintain highly reliable systems for quality improvement. For more than 2 decades, SRMC has achieved and maintained its accreditation and certifications with the Joint Commission and the Centers for Medicare and Medicaid Services, which attests to our quality of care. Maintaining our accreditation and certification with these regulatory entities ensures federal reimbursements for the quality medical services we provide. As we continue our pursuit of being a high reliability organization, an HRO, our goal is to achieve excellence across all services with zero patient harm. Our HRO team is spearheaded by Dr. Delphine Olivaci, and they are working to improve our patients' overall experience and our hospital consumer assessment of healthcare provider system scores, or HCAHPS scores. HCAHPS is a patient satisfaction survey required by CMS for all participating hospitals. Our goal is to achieve and surpass 50th percentile rankings in all domains. We will now present our SWOT analysis. To summarize our strengths, weaknesses, opportunities, and threats, we have included a snapshot of our SWOT analysis for your review. In closing, as we conclude today's testimony, I would like to highlight that our projected FY 2022 budget demonstrates marked improvements over our past budget performance. We are excited about the revenue enhancement strategies that we have put in place and the goals to improve our patients' experience. Through the commitment of our leadership team, physicians, and staff, and with the guidance and oversight of our governing boards and the support of the administration and this legislative body, we are encouraged about the future of SRMC. Despite the challenges conveyed in our presentation, such as uncompensated care, lack of capital funding, and the dire need to rebase our reimbursement fee structure, we hope to forge a brighter path forward for our employees, our organization, and our community. As you will hear in the presentation by Mr. Smalls, there are great plans in store to rebuild and modernize all three facilities. We are especially thrilled with the progress that is already underway for the Charlotte Kimmelman Cancer Institute. Our ability to restore cancer treatment services using radiation therapy will restore as a much needed service in the territory. Undeniably, SRMC will continue to face external threats such as ambulatory surgical centers, reimbursement shortfalls, and a change in payer mix and the effect of COVID on the economy. However, we remain committed to navigating these challenges to ensure that we can continue to provide the highest quality care. We will continue to enhance and complement our service lines to avail critical care services needed to treat and care for our patients right here at home. In closing, I would like to thank Governor Bryan, his administration, and this 34th legislature for the ongoing support for our healthcare system. Our team looks forward to working collaboratively with you and the community to ensure that Schneider Regional Medical Center is the best it can be. Our highest accolades are reserved for all the hard-working employees of the Schneider Regional Medical Center. None of our accomplishments could have been realized today without their commitment, hard work, and tireless sacrifice to place the patients first. We also want to give a special thank you to our patients and their families for entrusting us with their health care. Our patients are indeed our bosses. Without them and their faith in us, we would not be able to stand as a healthcare organization and be able to foster positive impacts on our community. Mr. Chairman, we thank you again for the opportunity to appear before this committee. We are available to answer any questions you may have.
Thank you, Dr. Amaro, for your testimony. Good morning to the people of the Virgin Islands. Good morning, colleagues. Good morning to the testifiers. I want to welcome Senator DeGraff, Senator Carrion, Senator James, and Senator Potter. Thank you for coming. I also want to thank Senator Janelle Sarro for starting the meeting. I just got over on a flight. I was hard getting flights this morning. And her staff, Simone, Keandre, and Kayla. Thank you guys for getting this meeting started. A lot in your testimony, Dr. Amaro, areas I want to highlight and applaud you for. Some other areas where we'll ask the critical questions. Before we begin with the 6-minute round, colleagues, I got to go to my engineer friend, Dr. Smalls. Engineer Smalls. You can't be an engineer or a doctor. Engineer Smalls. And it is not a relevant question to Snyder, but it's a question that we need to get an answer for and put on the record. And that is the status of the mechanical room at Wang Louis Hospital. No Snyder question, but you have a, no, that's all right. We need to know. So just for the public record, so we can know where we are and as a legislature know what we need to do. I know that there was a bid opening early July. What is the status of that particular project? And then we'll go back to Snyder.
Good morning, Senator. Good morning, listening audience. For the record, Senator, we did have a procurement, and we will be able to make a public announcement, I presume, as early as the first part of next week, relative to that bid. We are moving forward, and there are great things in store.
Okay, so I will talk to you offline to get some more. Now we'll go back to Snyder, and we will, if I go to Senator Blyden, I'm happy. Yes, go ahead.
Oh, no, I had a brief little testimony.
Oh, you did?
Yes, Senator.
Okay, proceed.
All right. Good morning, Chairman Kurt Bailey and other senators present, the viewing and listening audience. For the record, my name is Darrell A. Smalls, Executive Director of Hospital Facilities and Capital Development for the Territorial Hospitals Redevelopment Team. As I presented during the July 1st, 2020 budget, the Virgin Islands Government Hospitals and Health Facilities Corporation, through the Territorial Board, which ultimately has oversight responsibilities for the Governor Juan F. Louis Hospital and Medical Center and the Schneider Regional Medical Center, established the Territorial Hospital Redevelopment Team. The primary purpose of the redevelopment team is to manage and oversee the planning, programmatic design, final design, bidding, project management, construction, procurement, and closeout for the redevelopment of the Juan F. Louis Hospital, the Roy L. Schneider Hospital, the Charlotte Kimmelman Cancer Institute, and the Myra Keating Smith Community Health Center. To date, the major accomplishment of the redevelopment team has been the successful solicitation, selection, and awarding of contracts to architectural and engineering firms for the redesign of our hospital facilities in St. Croix and St. Thomas, respectively, the Cancer Center on St. Thomas, and the Health Clinic on St. John. One of the main objectives of the redevelopment team is to facilitate a centralized effort focusing on the redevelopment of our hospitals and our health facilities. Equally important, the team approach provides for a single source of truth for the related disaster recovery projects for the hospitals, which will inevitably lead to better accountability by the Territorial Board. Collaboration, transparency, and accountability are of utmost importance to the success of the redevelopment team. I am pleased to report this morning that with respect to the Charlotte Kimmelman Cancer Institute, after months of verbal assurances, FEMA provided official documentation dated June 6, 2021, approving for the full replacement of the Charlotte Kimmelman Cancer Institute. This official notification paves the way for the cancer facility to be reconstructed to industry standards in accordance with the Bipartisan Budget Act of 2018. The next step, which we are actively pursuing, is the approval process to determine the cost to rebuild the shuttered facility. Meanwhile, EYP Architects and Engineers, who was selected as a result of RFP 013-C 2020 AE Services for Hospitals, has been actively engaged in the programmatic planning of CKCI with the leadership of SRMC since the execution of their professional services contract in April 2021. Similarly, we have executed the professional services contract with EYP for the project design and construction management services to reconstruct Roy L. Schneider Hospital. While we were optimistic for a prompt resolution that would have facilitated the commencement of the reconstruction efforts, we continue to work with the assistance of Wood O'Brien through the settlement agreement process between the Federal Emergency Management Agency and Schneider Regional Medical Center. I want to assure this body that we continue to express the urgency with FEMA through the Office of Disaster Recovery to arrive at a final determination as we find ourselves facing yet another hurricane season since Hurricane Irma and Hurricane Maria severely impacted our facility in September of 2017. Understanding the urgency, FEMA has proactively begun the scope and costing for the Roy L. Schneider Hospital while the final determination continues to be evaluated. Typically, this step commences after a determination is made. I am pleased to report this morning that with respect to the Myra Keating Smith Community Health Center, FEMA has provided official documentation dated July 1st, 2021, approving for the full replacement of the facility. This official notification paves the way for the health center to be reconstructed to industry standards in accordance with the Bipartisan Act of 2018. As this determination was just made, who was selected as the architectural and engineering firm as a result of RFP-013-C 2020 Services for Hospitals for the project design and construction management services to reconstruct MKS will be under contract and will proceed without delay. As is the case with all reconstruction projects, the first step is to begin with the programmatic design to determine the services to be provided, and the estimated costs for construction are in line with the established budget. Both the Charlotte Kimmelman Cancer Institute and Myra Keating Smith Community Health Center remain closed for all patient care. With the closure, radiation oncology services cannot be provided. However, patients requiring chemotherapy can receive care from providers within the territory. On the island of St. John, the modular facility, which was erected in the parking lot of the former health facility, continues to provide all pre-storm level services to the residents and visitors to the island. SRMC's leadership to this day remains steadfast in the decision to invest in temporary repairs to mitigate further damages to our 3 facilities. The decision to undertake temporary repairs at RLS instead of pursuing a modular structure in the interim has enabled for the continuation of much needed healthcare services for our community in a clean and safe environment. While the decision to undertake the temporary repairs was made in the best interest of patient care, it has led to the need for repeated justifications and clarifications that the repairs were in fact temporary as opposed to permanent repairs. Some of the next steps for the redevelopment team is to engage the various stakeholders, which include but are not limited to the territorial board, the respective leadership team from each facility, the medical, clinical, and non-clinical staff, other government agencies such as the Department of Health, the Department of Human Services, the Department of Justice, as well as this body, to name a few. We look forward to continuing this effort, which will enable and facilitate the development and construction of the state-of-the-art, functional, resilient, and self-sustaining healthcare facilities for the residents and visitors of the United States Virgin Islands. I want to reiterate Dr. Amara's thanks and appreciation for SRMC staff, our temporary staffing through PAFFord, and all other medical and clinical professionals who have helped us through this pandemic. This concludes my testimony.
Thank you, Mr. Smalls, for your testimony. Colleagues, let's go to a 6-minute round. Senator Blyden. Mr. Smalls, can you send email the testimony to us? We don't have a copy.
Okay, I will.
Okay, thank you so much.
Thank you so much, Mr. Chair. Good morning to my colleagues. Good morning to the listening and viewing audiences, staff, central staff. Good morning, Dr. Mara, to you and your management team there with you and virtually, and thank you so much for that most comprehensive testimony. I really appreciate the testimony. There's a lot of good information in here, and I want to say congratulations to your many accomplishments in such a short term. I know many different departments come in front of us and agencies, and we give recommendations, etc. And you really don't see any movement. But over the last several years, we have seen significant improvement from your team, and we want to say thank you so much for that. Especially when it comes to the CraneWest software, the in-house billing, 4 quotas, the online bill pay, etc. You guys are doing the right thing on behalf of the people of the Virgin Islands and on behalf of your team. So thank you for that. It's a budget hearing, of course, so let's go to the post-audit report. Good morning, Madam CFO. Let me ask you, let me start off because I believe it was addressed, some of this was addressed in the testimony, but page 4 of 57 when it comes to the post-audit report. When it comes to advertising and promotion, there have been an increase of $34,000. The increase, the $34,000, what will that go towards? More advertisement of bringing local nurses home? What area is that that money going towards when it comes to advertisement and marketing? Or
If I may.
you can speak to it if you want to.
Yes. Thank you, Senator. Thank you for the question. We, as you stated, want to be able to promote many of the wonderful things that SRMC is doing and, have not been able to get out there before. So we've increased our advertising in posting positions nationally. We've increased our advertising, especially through commercials and so forth. Through the pandemic, it was extremely important for the public to know what our processes were, the things that we're doing, so that they can know that not only are we conducting safe processes throughout the pandemic, but we're also making our hospitals safe for patients to be able to come in and receive their care.
Okay, very well. Also on the professional service contracts, I know you mentioned in your testimony also that you have 98 and you gave a breakdown, but as I went through the contracts, before you gave that breakdown, there are several it's more than 4 that is not going to be renewed, but there are several here that have expired, and what's the status of them? For instance, that the Medical Data Center, the Medical Data System Inc., that expired in 2017 November, and then it's stated in 2020 we negotiate the contract rates of bad debt. It's not clear to me. It was renegotiated in 2020 when it comes to bad debt, but where are we going from there? What's the status of the contract? What's the terms of the contract? So it'll be good to know those type of information moving forward. Okay, it's a lot. It's a long list. I don't want to go through it at this moment, but moving forward, it'll be important to put that information in there. Okay, let's go to page 13 of 57. That's the federal grants. And on page 14, you have a grant for the hazardous medical waste disposal of $106,061.89. None have been expended thus far. What's the status of that and what's going on in that space?
If I may, I will defer to our interim interim facilities Vice President, Mr. Darrell A. Smalls.
Sure.
All right. Good morning, Senator.
Good
yes,
morning.
The territory did receive that grant, specifically the Schneider Regional Medical Center. We have not expended it to date as a result of, post hurricane, where we had originally planned to physically put that equipment. We could no longer put it there. However, we continue to maintain our grant reporting to ensure that we don't lose it. It is our intent to bring it online as soon as possible once we can identify a spot that will not be impacted when the facility is being reconstructed.
2 minutes.
Okay, thank you for that. Let me ask about this other two on page 15. And you have one for $10,167,181. The CARES Fund related to COVID pandemic. That's a federal grant, and you have another FEMA grant for $4.9 million. Can you expand on those two for me, please?
Sure, Senator. I will defer to my CFO, Dr. Pamela Gallagher.
Okay, very well.
Good morning. Good question.
Morning. Can you speak into the mic and
Sure.
state your name?
Better?
Much.
Better. Pamela Gallagher, Chief Financial Officer, Schneider Regional Medical Center. We actually received $13.4 million in CARES. Some of that came directly from the OMB, so we received more than that. The other monies were put, and we're still in the throes of reporting that to the various agencies, of all the additional costs for COVID, everything from isolation procedures to additional staffing, things like that. So all of that money has to be accounted for and reported through a portal. Probably more information than you want to know, but that's what they're in process, and it has all been spent. And now we just have to determine the regulatory reporting requirements that we're doing now that has to be in by the end of September.
So you stated that it has all been extended, it has been spent, all of it?
It has all been spent, yes. Just the reporting is left.
Oh, that's good news. That's good to know. Appreciate that. Let me ask you, how many vacancies do you have, Dr. Mara?
Mason, but I know.
Ralda Mason, Executive Director of Human Resources. Presently, we have about 98 vacancies.
How many of those vacancies are considered critical areas?
50 of them are critical right now, which are clinical positions, as Dr. Mara referenced in his testimony. We're focused mainly on medical technologists and nursing, health, and other clinical positions.
And,
Time.
and in terms of onboarding individuals, what are we doing to assure that we fill those vacancies?
The recruitment, advertising, marketing efforts that have been ongoing, both locally, nationally, internationally, efforts that we're making towards recruitment.
How has the response been thus far?
Not as great as we would like it to be. We realize that we're not alone. We're actually swimming in deep waters. Nationally, we have the same thing going on, which is prompting us to pursue other opportunities. We are looking at reaching out to neighboring islands, which we believe will be a good opportunity for us to onboard individuals. We know that there are some challenges perhaps with regulatory or immigration type restrictions, so we're pursuing those opportunities.
But Dr. Amara mentioned a visa program. I believe
Correct,
that's a
correct.
good program, and that's a good way to go to onboard individuals. But I want to thank you guys for all you're doing. And Mr. Chair, I don't want to abuse my time. Thank you so much for the time.
Thank you, Senator Blyden. Senator Francis.
Thank you very much, Mr. Chair. Good morning to you, my colleagues. Good morning to the people of the Virgin Islands, and of course, good morning to the testifiers from the Loretta Still Snyder Regional Medical Center. Dr. Omar, I want to thank you very much for your testimony. We're very impressed with the testimony and the level of progress the facility has been able to make under your leadership. Thank you and your team for having this testimony together. I also want to commend hardworking employees of the Royal Hospital, and again thank them for continuing to do their part during this difficult COVID era. I want to commend you on your ability to retain the UDI students for 3 years that graduated with NCLEX, and 2 employees that served in other capacities. How important is it for you to continue to embrace the local nursing space? Can you just speak to that?
Thank you very much, Senator Francis. We have a specific interest at Schneider Regional to bring, any locals into the organization that have been putting in the time, whether it's from the University of the Virgin Islands or those that have left abroad. We specifically know that we want to bring folks home. We want to bring folks into the organization as they have the ownership. They have the buy-in to give back to the community and to be able to serve the community because they grew up and they lived here. But particularly for those who train at the University of the Virgin Islands, they are also training within our hospitals during their education, and so they have a particular knowledge of our efficiencies, of the things that we do, and it becomes a seamless transition once we can encourage them to come into the hospital and we can do the things we need to do to retain them, away from other places that may try to attract them.
Thank you very much for that. I'll put it in perspective. I've spoken that for the week. We'll take a page out of my hospital book. Share Health Hospital Human Services Committee. Again, we have been advocating for similar hires from can you speak to any discussion with Dr. Hall with respect to medical school? What is the collaboration that's occurring right now in terms of the UTI medical school process?
Thank you again. We have had discussions. Dr. Hall actually recently visited our medical staff to discuss the reinvigoration of the medical school being resurrected or being, that process starting again. I have been in conversations with his staff as far as this project. They have been, I think, very excited by new funding that has become available, to get this process started again. And I'm a physician, and as a physician, we are excited to teach. We are by trade and by our training an apprenticeship style of learning. And so when a physician sees a medical student or a resident come in, it only helps us really to be better in what we do. I think it really helps the entire organization to raise its level of knowledge and aptitude, because there's nothing like a medical student or a resident to call you out if you do something wrong. So you have to be prepared. But it just helps you to be cutting edge. And so we're excited for that program to get up and running again, and I'm a huge supporter of that.
In regards to the, I noticed that the bills that you're spending on the bill, is there any plans to be efficient for the facilities? Thought about panels going to address this?
Sure, and just for the interest of time, I'm going to defer to my interim VP Facilities, Mrs. Smalls.
Good morning, Senator. As you have heard me continue to say across the territory, when we're rebuilding our facilities, we're looking at resiliency and the ability to have, like you said, solar panels or any type of energy saving measures. All of that will be implemented in the new bills.
Well, all we have to regards to the is there any particular timeline that you're working with? I know that all of this needs to materialize in terms of approval for the bill, timeline, and also speak to what is being done in respect to cancer care.
Well, I'll speak specifically as it relates to the facility. How soon we would like to get it online? Of course, we would have loved to have gotten it online yesterday, but we have received the final determination from FEMA, so it is a full rebuild. We are meeting right now with our architects to come up with that final plan, that final design for the facility. So we hope in short order, less than a year, we're going to actually have an RFP out for a contractor to begin rebuilding the facility.
Since the 2017 storms and the destruction, the impact that has occurred on CKCI, we've moved a lot of the cancer care to the private facilities, to the private offices of our credentialed providers, who have done an excellent job standing in the gap to care for all the patients that require at least hematology and oncology care. The one missing piece would be, of course, radiation oncology, a huge, huge, huge missing piece that needs to return to this island. We see that, and this is why the first institution we're working on is CKCI, because that is what we want to get up and running. That care, unfortunately, has to happen right now off island, but we are working expediently to get this care back up and running on the island again.
To the projected FY 2022 revenue increases, if you could just be a little bit more specific in the areas that he intends to hopefully achieve those revenue projections that you have sort of stated, I'll appreciate it. Thank you very much, Mr. Chair.
Thank you, Senator Francis. You may respond, Dr. Amaro.
Sure. I will start and allow my CFO to finish, but we are increasing revenue based on many service expansions. We believe, and I will speak as a homie, that our lab is the best lab on island, and we believe that we have many opportunities to expand the services there, and we are doing so. We are expanding our medical services, as you've seen some of them already with our total joints, our pediatric cardiologists. Many of these things we will expand with that. We have new diagnostics within our radiology department, a new fluoro room, a new CAT scan, and we're going to be doing new things with those machines that we received to be able to expand services, be it with cardiac CT, cardiac calcium scoring, or with swallow studies. There are a wealth of things now. As we get the capital, we'll be able to do. There are many financial improvements I will allow my CFO to comment on.
Thank you. And I just want to tell you, it is a privilege to be here and be working with the folks. Well, we have the traditional finance things like charge capture and, reimbursement, contract negotiation. It's the folks here, the nursing leadership, we met with them to discuss their budgets, and they're so invested. They're recognizing that there's opportunities and things, and we have in-house legal counsel that's helping us reduce contracts. So one of the ones that you had mentioned. So there's just so many opportunities, but it's all realistic here, and it's because of the investment of the folks at Schneider. So we have so many good things coming.
Thank you so much. Dr. Amaro, going back to your ability to hire nurses from the UVI School of Nursing, the numbers are very good. However, I read where you said we have also engaged 11 new graduates who are awaiting the outcome of the RN NCLEX exam, and 2 of them are presently employed. Do we have a graduate nurse program where as soon as they graduate from UVI, they work at the hospital for 1 year and they're given the opportunity to pass NCLEX within the 1 year? That is what I've been pushing for in St. Croix and St. Thomas. You have somehow been able to capture them after they have passed the NCLEX, but how are we going to capture them as soon as they graduate from school?
So our GN program is not currently active. However, what we found is that with UVI students, the prep that they do at UVI is so well put together that students manage to pass even without the GN program. Just last night, I heard that one of the 11 passed. So we're awaiting that application.
Okay.
Also, their clinical rotations with us, as Dr. Amaro mentioned, helps with that process as well. So that from their second year in nursing school, they're already doing some of that prep towards completing the NCLEX.
And that is why I want the graduate nurses program, because they're well prepared, and if they're already on staff, when they pass NCLEX, it'll just be to convert them to a full RN. But they can come on, I mean, even if we make it a 6-month period to pass NCLEX, but I don't want to see our nurses going to private resources or off island without us having the first opportunity to capture all of those individuals. So if we can just develop a program where as soon as they graduate, they're already doing clinicals with you. As soon as they graduate, that they'll be able to morph directly into the hospital, take the NCLEX in 3-4 months, and then become full-time RN.
And it is a really, really good program. We definitely are supporters of it. Of course, as in many things we would like to do, our rate limiting factor is always staffing. So you need to have the experienced nurses that are focused on those graduate nurses and not entertained within the work of the hospital, which right now, given our shortages, is almost an impossible thing to entertain. So we would like to be able to be so robust in our nursing that we can spare even if it's a retired nurse, to be able to train them. However, as you know, with the pandemic, that's a population that is a little bit cautious about being in an environment with COVID and so forth. So that's just the challenges, but we do support your measures on that.
And we also asked Wang Louis to have a discussion with Department of Labor with the Workforce Development Program, because there are some federal funds that we think can be utilized to really get this program going. We have apprenticeship, we have the Workforce Development monies, some $10 million. We just hired a company to develop programs. This should be a component, because this, I think that the hospitals are the perfect training ground to be able to expand certain professions. Senator Joseph, you're recognized.
A pleasant good morning. Thank you, Mr. Chairman, for the time. A pleasant good morning, colleagues, our testifiers here, as well as the listening and viewing audience. I want to really commend all of the team members you have on your team at the Roy Lester Schneider Hospital for your tenacity, for staying focused to assuring and also looking at not only maintaining but exceeding your performance indicators. I'm hopeful that you will be able to exceed. I know you said surpass. I'm hopeful. And whatever we can do here to assure that, please let us know. I noted in your testimony, Interim Chief Amaro, that you indicated that you're having some challenges with CMS in getting reimbursements for your outstanding services that you've provided. Could you expound a little bit on what some of those challenges that you have been faced with? Because you have a large balance of uncollected. You call it bad debt, and you said in your testimony on page 2, you said contractual adjustments are negotiated rate deduction and insurance companies and the reimbursement amount preset by the government programs like Medicare and Medicaid. What precisely are those challenges you're facing? Because we have a large population who may not have sufficient, and they're poor and may not have the monies to pay for the medical costs that they receive.
Thank you very much, Senator Joseph, for that question. So a couple things there. I'll try to, we could spend the rest of the day talking about this, right?
Please
so I'm going to
don't.
try to keep it, I'll try to respect your time.
Thank you. Kindly.
First of all, approximately 70 to 75%, depending on the year, of our patient base are basically either uninsured or underinsured, below cost, basically. The challenge with CMS that we discussed is multifactorial. It's very complex. We are charged by a cost-based reimbursement structure. In other words, it's based on the cost, a calculation factor that looks at the cost to the hospital. For Medicare, there's a cap. So whatever we run up in costs, if we run beyond that cap, we are going to have to eat that and absorb that. We are not going to get any monies beyond that cap. Most importantly, though, we are reimbursed at the initial year that TEFRA, the reimbursement structure that we're under, we are reimbursed in the initial year it was designed, which is 1982. In other words, as I had stated in my testimony, when they look at the cost of the hospital and determine what our reimbursement is going to be based on costs, it's not based on our costs. It's not based on 2021 costs. It's based on 1982.
So no. Is this across the board with every hospital facility in the United States, or is just here?
No, this is just in the outlying islands that still reside under this TEFRA reimbursement structure. So this is unique.
So this is something that we have to escalate to the federal level then?
Exactly. This has been escalated.
It has been escalated.
And it is being worked on, but we are, in HR 3434 Act, it is part of what is being looked at to get us rebased to a more current year for reimbursements. That is then going to be, and it's not to necessarily be off of TEFRA, but we just need TEFRA to be updated here in the Virgin Islands so that our reimbursements are more consistent with the costs that the hospital actually incurs.
Okay.
2 minutes.
I'm going to leave off of that because I have a whole bunch of questions myself. I wanted to ask you, because I saw that you have this wonderful system and you are collecting more of your bad debt because of the employees that you have put in place as well. And if you could provide to us how much you have reduced your bad debt and your collections over the past 3 years. So we could see definitely that you're getting some return on your investment. And then I want to switch quickly to the post-audit report. In the post-audit report, it had, and I'm dealing with the bad debt, and I'll stay on that. It has that you owe a total of $10,323,741.77. And this is dated back. I'm looking at the bottom line. It's listed here in the post-audit report on page 57 of 57. And these are some of the costs dating back from the onset of this century, 2020. Do you think that is accurate, or have you paid down some of the debts that's there?
I'll handle the second question first. The bad debt is actually what's owed to us. When we talk about bad debt, we're talking about what the debt that is incurred when a patient is unable to pay in accordance with the bad debt policy that the government hospitals have.
Yes, I stand corrected. It's outstanding obligations. I'm so sorry. Thank you kindly.
No worries.
Outstanding obligations. So I have your outstanding obligations. I didn't see that part of the appendix listed there. Typically, I account, yes.
Time.
Mr. Chairman? Okay, so tell me about the outstanding obligations that I just mentioned, which was $10,323,741.77. That's what we have as a bottom line in our post-audit report.
Page number?
It begins on, oh geez, it's an appendix 2. And you could find the bottom line to it.
Go
ahead.
I'm sorry. So it's a little bit different than what we have currently recorded and what's in my testimony. Our AP is actually 13 million approximately.
So it's more.
It's more than it is more. But you know what we wanted to highlight is we've been diligently working this down from just about 4 years ago. This was over 40 million.
Wow.
And we have worked this down through our reimbursements and through a lot of our cost-cutting maneuvers and so forth, have worked this down to the 13 million. We have a lot more processes in place to continue to work on that. However, it should be noted that a significant reason why this debt remains is because we have significant challenges with what we term as cash flow. And when we talk about that, if we're not regularly receiving our cash from all the different entities that we should receive it from, it then unfortunately has to affect our ability to pay our vendors and so forth, because we need, at the top of the list, we have to be able to pay our employees. So our AP is going to, definitely be affected by that.
Understood. Mr. Chairman, one more question, please.
To conclude, go ahead.
Thank you kindly. Now, you mentioned something that I am very familiar with cash flow. Which entities you typically have challenges receiving your cash timely? Kindly list them.
So we are working with, of course, Medicaid funding. When we get our local match or our federal match rather, we want to be able to submit, get that turned around, and back to us on a weekly basis. Regularly. We are doing a lot of work with the Department of Human Services and the Department of Finance to make sure the communication, the logistics are right, and they have been very, very good partners in making that happen. It's not always come to the level of flow that we would like, but that's just sometimes inherent within a government that has 19 holidays and some other challenges and stuff, but they're working hard. But we have a lot of work to do to try to make that work very, very well. Pamela, if you would like to expound on more.
I just want to echo that. The intergovernment agencies have been wonderful. Even WAPA was so helpful when I got here, just trying to understand. And we still have a little bit to go, especially with that cash flow. If we could get that on, especially with Medicaid on a weekly basis, if we bill cleanly and things like that, if we could get that, that would really help us a lot.
Okay, thank you kindly, Mr. Chairman, for the time. I appreciate it deeply.
Thank you, Senator Joseph. How long is it taking you to send out a bill? By the time the patient leaves the hospital, how long does it take to?
So what you're referring to, sir, is how long does it take for the patient to receive the bill?
Yes.
That is very complicated, and I'm glad you asked, because I'll explain that. When we, be it my private office or the hospital sees a patient, we have to send that bill first to the insurance company. That has to be processed by the insurance company, see what is paid before the patient can actually receive a bill. So it gets very, very convoluted because the patient tends to see a bill sometimes weeks, sometimes months, based on the length of time it takes for that insurance company to return that. That is not so much on our control, but I think in what you're asking, what we can do a little better with is keeping the patient updated so that they know where they are in the process or where we are in the process before they finally do receive a bill.
Okay, let me change the question a little bit. How long does it take for the insurance company to get the bill, or Medicare or Medicaid to get the bill?
We strive for 5 days, but some of it's a little longer depending on late charges and things follow up, and there's back and forth, but our bill drop is 5
Okay.
days.
Slow down a little bit for us.
Okay, 5 days is our target date to drop bills to the insurances, Medicaid, Medicare, everything like that. We get everything in within 5 days, and then usually within 2 weeks, those bills do drop.
Are
To
you,
ensure,
okay. Are you capturing all of the costs incurred by the patient? Or are we still, the bills pretty just general and the areas that we're not capturing because of the lack of details?
that is an excellent question. We now have a late charge reconciliation, and that's part of the monthly process. So we identify them by area, and the response has been phenomenal. Like, lab, make sure they're in by the end of the day, things like that. So that's a great question, but yes, they're going out much cleaner. All the
Okay.
charges are in there and things like that. We still have some work to do, but there's an overall reconciliation process for late charges or just to make sure we capture everything. We're also in the middle of a charge master review. We're in the middle of a charge master review to make sure that our charges are appropriate. We have all the CPT codes, HCPCS, all that's on there. So that is currently underway by department. So that will also help us. Each day, it will get better.
And last, and then I'll go to the next senator, because I'm sticking on billing for a little bit. 'Cause billing is one of the most important component of us being able to survive. Are the doctors submitting all of the requisite charges, exactly what they're using, et cetera? Are we charting everything that is taking place with that one particular patient, that we're not providing them with X, but it's not on the bill?
So, and you're hitting all the points. I mean, you're doing, as far as like you said, the billing is where it's at, right? I mean, we do the work, we want to collect what we've worked for. To the point that you made, one of the initiatives we took as we're taking, as we pointed out, charge capture, all these things that we're doing, we're looking at every small point to make sure we're doing it right. We actually engaged Dr. Reva Richardson. She is now our physician representative for the revenue cycle, who does exactly as you're stating, making sure that the physicians are doing all the necessary things. So we have eyes on it by a physician to work with physicians so that the physician billing will be right and be brought forward clean so that we can send those out appropriately.
Okay, and the lack of the Meditech system doesn't allow us to have the barcode where we could swipe everything, right?
That is correct.
How much would that help in terms of billing? If you have the barcode, the patient come in, they have the little barcode, and then every medication, you just click, it goes directly into the record in terms of billing. How much would that help in terms of revenue? What do you think that would generate?
I'll start off. I mean, my CFO will probably take your ears off with this, but I mean, it's monumental in process and efficiency, avoiding errors, avoiding anything missed, monumental in having an updated electronic medical record system to be able to have these efficiencies, bill appropriately, be able to track and know what's missing and be able to recover that. Dr. Gallagher.
That's true, and that's most of my background is technology and optimization and things. So, and the IT, I can't say enough good things about them. They're helping us do that. They recognize the economic reality of putting in Expanse tomorrow and those things. So we are expanding on some things. We are starting some electronic initiatives prior to Expanse, but it's critical, not only from the charge capture and things like that, but from the quality perspective and the different requirements. So it's
Okay, if we're supposed to fund it.
Ways to fund it?
No. If the legislature is supposed to fund that particular initiative, how much would your revenue grow? Well, what would be the improvement? What would be the bang for the buck? If we fund this, it would allow you to what?
I'm
Five
gonna,
5% more, 8% more?
I'm going to get back to you with a realistic. It takes me a while. It took me 3 years to do a doctorate in that, so I'm going to do a little bit. I'd rather get you an excellent answer for that. I'll follow up with you.
Okay, so you
What the
provide
return on
me with
investment
an
would be on that.
analysis?
Yes, a return on investment for that. It'll be a little bit. It'll be like the exact dollars in. It'll have quality measures in it. But yes,
Okay, and you could get that to me by when?
I need 2 weeks. I got to put some other things in first. 2 weeks, okay? Or do you need it sooner? I can put other stuff
Yeah,
over.
2 weeks, that's before the budget markup. So
Okay.
2 weeks and you'll submit it to my office.
Okay.
Okay, thank you so much.
that.
Senator DeGraff.
Thank you, Mr. Chair. Good morning, colleagues. Good morning, testifiers, all of you listening and present. Dr. Amaro, how come you're still interim, right?
I only take care of things I can take care of, sir.
Okay, well, I bow to them, let's get it in check first, man. SMRC got my full support, 100%, because I noticed when we start off with SMRC, Mr. Chair jumped to, and Wang Lui. Wang Lui got my full support too, so, but again, I noticed when you spoke about GERS making it hard and you're having problems. How much additional money did you ask for? You went from the allotment what they were giving you in 21 or from 25 million was from the general fund, and now you're asking for 2750.
The recommended submission was 26,750.
26,750. All right. So that's $1,750,000 over what you're getting before.
Yes, sir.
Would that take care of what it is you need? No, right? I mean,
No,
I
sir.
don't need to be a mathematician, scholar to know that that's not. Especially when you're speaking now of the most important element in your facility is your employees.
And it's correct.
And that's why ours happen. Employees and infrastructure, where you're housing them in. Now, GERS, how much is owed to GERS?
We have no debt to GERS. We are fully paid.
Good. And you have it in your budget for how many retirees are you looking at it for, have to be going in for the 22 budget are we looking at?
I will defer to my human resources.
And are they paid up to
Director.
date?
We don't have any, for any retirees that we've received invoices from the retirement system for, we've paid them. So we don't have any outstanding debt for any of our pending retirees.
Good. So
As
anybody
long as
retire-
GRS provides us with those invoices, we pay.
Good. So they shouldn't have to wait a year or two. Okay, good. Now you said you have 9 collective bargaining units. They are in the interim now of negotiating. Because one received, you say, from the emergency room, they received the increases in 21.
Correct.
Everybody was fully paid.
We didn't pay the retro payments on them, but we have implemented the increases.
How much retro are they owed totally as an entity? How much retro are we talking about?
For the emergency room physicians,
For the ones who received the increases, yeah.
for the emergency room physicians, their retroactive payments are upwards of $200,000. We have not paid those as yet. The other entities that were completed negotiations, their retroactive payments have been made already.
Okay, so for the ones outstanding, do you have it in this budget to pay them?
No, sir.
How come?
Do we have it in the budget as far as an
In the
estimated?
22 budget to pay the outstanding retro monies? That's what I'm asking.
So anything that, for the emergency room physicians, if you look at what we provided, it is included in there in the $866,000 as far as estimated portions. We do have it included as an amount that we will need additional funding for.
That's a part of the $1,750,000 you're asking for in the general fund?
No, sir. The $1,750,000 increase was a 7% increase provided and approved by our governing board. That money, as stated in the
Was in personnel.
well, it's the whole amount does a very good job of matching the bad debt and unfunded, uncompensated care. So that's really what it specifically. In other words, the 26,750 matches what Schneider Regional Medical Center did not receive in payments for the care they provided. This is not entertaining capital monies. It does not entertain increases in employee contracts or anything like that. It is simply, we saw this patient, they couldn't pay us, and you reimburse us for it. That's what's being entertained in that money.
Okay, good. So, like I say, back to the employees, the monies for the outstanding persons, you have that money to be cover that retro.
It would have to come as part of our operating expenses.
Okay. Does presumptive eligibility, do you have a unit dealing with that for bad debt, to address your bad debt?
So with presumptive eligibility, it helps our bad debt because the more we can convert, well, first of all, those patients presenting that are eligible for PE, presumptive eligibility, are automatically, if they're eligible, automatically granted a temporary Medicaid provision. That helps to get the hospital paid. That's one less bad debt that could have been received, or payment that would not have been received, I should put it that way. If we can do, and I say that as a...
Excuse me a minute, do you have a team doing that, to collect all that money? Do you have a team working presumptive eligibility
Yes.
to collect a lot of your bad debt?
Yes, our patient access team works on that.
Okay, good. Quickly, was there savings, or is there going to be a savings from your oxygen? Will you say you'll be producing your own? What will be the savings from your oxygen?
So, we spent about $1.1 million a year for liquid oxygen. It's going to remove that. When you consider and add in the maintenance, the yearly maintenance of the oxygen generator, the savings is going to be realized at approximately a little over $800,000 a year.
So
and that's in the budget.
And you'll be coming online for that, and would you be able to sell to other private entities?
I will defer to my VP of Facilities.
If I may wrap up with it, Mr. Chair. Okay, good.
Yes, you may.
Okay, yeah, so you will be able to save 800,000, and also you'll be able to sell oxygen. Okay, so go ahead.
Good morning, Senator. That
Good
is
morning.
absolutely correct. We will be able to sell to other entities, whether government or private.
And you have a projected amount as to what you look to probably recoup from that?
We haven't been able to get it, develop that as yet. Once we identify those individuals or entities that would be, in the market, then we'll be able to go from there.
And finally, Mr. Chair, I just wanted to ask in regards to cybersecurity. Do you have all your systems in place to address the cybersecurity issue? Because we've seen that as a major issue, and with the uptake also in the Delta variant of COVID, do you have more COVID funds to start addressing the impact of that if need be? And I can answer in the chair time. Thank you for the time, Mr. Chair. Just two questions.
Thank you. So I'll answer the COVID question. I'll defer the cybersecurity to my Executive Director of IT. COVID funding has been discussed as far as being able to, improve and increase our personnel, particularly permanent personnel. So that has been a conversation, even as from the executive branch, to see how we can receive extra funding to make that more permanent, to make them more whole. The discussion of these employees, I think it was asked before, we are in competition. I mean, the United States, some of these hospitals are paying nurses almost as much as physicians in some instances to be able to work for them. That is really hard for us, and we have to be able to meet that challenge some way, somehow, to be able to even have a nurse to care. I mean, we did a great job with the infrastructure to build it. We have 100 beds ready to go, but if you don't have the staff in, then we built nothing. To my Executive Director of Information Systems, Brandon, for the cybersecurity. It's muted, sir.
Your device is muted. Yes, go ahead now.
Okay. Executive Director of Information Systems, Brandon Richardson. As it relates to cybersecurity, we have upgraded the majority of our workstations. We've put in the latest and greatest antivirus software. We've moved towards a portion of our systems being online, and we are currently doing an RFP for the other section as it relates to as it relates to EMR. Can you hear me clearly?
We were hearing you at first, and then it came in with an echo, but I think we understand what you said.
I think we got it.
I think we got it.
Yeah.
So thank you so much.
Thank you.
Dr. Gallagher, how do you pronounce your last name? Gallagher. What's your background? I see the doctor before, so I'm intrigued to know what's your background.
Healthcare, mostly healthcare, some education, but all different hospitals, acquisitions, mergers, a lot of interim work. Last place I was in Kentucky during COVID. They did bought out by another system.
Which system were you last? Say it again.
Kentucky Baptist Hospital in Kentucky, not the Florida one, the
Okay.
Kentucky one.
Okay. All right. Thank you so much. Senator Carrion, you're recognized.
Good morning. Good morning, Mr. Chair. Good morning to the testifiers, and good morning to our viewing and listening audience this morning. Dr. Amaro, I clearly want to join some of my colleagues in congratulating you for the achievements you have aimed thus far at the hospital. So it's commendable to see how some things have improved, how you have reduced your accounts payables, and you've made some improvements in various areas. So we have to commend you for that. So thank you in that regard.
Thank you.
On your testimony, page 3, you speak about the NPSR, and that it's projected that in FY21 it would be approximately 49 million. What is the current number up to date?
I will search for that for you, sir.
Okay. And yeah, I was interested to find out where we are now. And I see that you also projected that for FY22 will be around 58.6 million, and almost a 9 million increase. I'm interested to find out to what you attribute that increase for FY22, and what are the key initiatives that you factor into this increase? If you could elaborate a little bit on that.
Okay, thank you. I could, but I think it would be done much better by my CFO on both answers, so I'll defer to her.
We have a lot of initiatives related to that, and they add up to that amount. Like there's $800,000 just in the emergency room alone, and that is net dollars from charge capture and improving our, working with Dr. Richardson and things like that. Most of the reported levels are 2 now. I don't know if you're familiar with emergency rooms. Most of them should be 3 or higher with the type of activity and patients you see. So we went through and looked at that. So there's 800,000 just there. Infusions and injections, improving that process is another 200,000. We have some expense and different services. The VP of Operations has some great things going on, everything from lab to radiology to the interventional cardiology. So we have it broken down by initiative, but the main ones are charge capture, improving our collections is the main thing, and of course, expanding services.
Okay. Maybe your CFO could help you, Dr. Amaro. What is your actual for FY for this year?
Right now, I have only through May is 32.2 million, and we have 32 million. Yes, so far through May only. We have some initiatives to push that.
So you think you're on target for your projected amount?
We sure are trying. Yes.
Okay. And also, in regards to the presumptive eligibility, the PE, I know that it has been it has created impact. Can you clearly share what are some of the benefits you're going to receive?
So, I mean, as discussed, the presumptive eligibility is going to is a wonderful program if it really comes to fruition in total, because it has allowed many patients that would have been unfunded or not be able to pay their bills when we had to see them, affect our finances negatively because we would not see anything from there, and all of that would have to be realized or reported to this legislative body as the losses to be incurred for the reimbursement for uncompensated care.
2 minutes.
That PE allows these patients now to get immediate. It's a self-attestation, so it's not even like we have to wait for them to bring documents or anything like that. For 60 days, they become eligible when they walk into the emergency room, meet the criteria. They do have some criteria to meet. But that criteria can be met, again, just by the way they report that information, because we are not a part, we don't get involved with how they fill that in. We just give them guidance, we give them the application, they fill it in, and whatever they say is what we go by. And if whatever they say meets the criteria for PE, they will get Medicaid PE, and we will get paid by that. Even if later on they don't meet criteria for full Medicaid, even if they don't meet, they never met criteria by their self-attestation, we still get paid for those services. That is phenomenal and has made a big difference.
Well, thank you for sharing and expanding on that. Now, on that same line, I do know, and according to your testimony, that uncompensated care is a huge issue for our hospital. And clearly, you stated in your testimony. So other than the rebate adjustment that you spoke about, is there any other way the hospital can recover that? Has the team explore any other creative way to cover for that uncompensated care?
Yeah, I mean,
I know my time is running out.
Yeah, I'm going to be respectful of that. So very quickly, other than the rebasing, I think the single biggest thing I can think of that makes the biggest difference is timely auditing with the cost reports and timely reimbursement with those cost report auditing numbers. And I have to stress that the providers get all the money they are due once that report is provided and it establishes what the hospitals are owed. In other words, we worked for it. It is established that that we are owed. If we have increased costs above what was predicted, then we are owed that cost from the Medicaid patients we have seen, and we should then recover that full amount of reimbursement, whatever it is, so that we can realize the profits, not the profits, but at least the reimbursement for the work that we've done.
Time.
If that money is taken from the hospitals and displaced to other places that didn't work for it, I think that hurts the hospitals immensely. And if we were to able to get that money, other than the rebasing, I mean, we could talk about a bunch of other things we don't have time for, but that would be essential. So when we get it timely audited and we get those things returned, because it's late now, we haven't received any auditing reports since 2014. If we can get that updated, push to get that updated, and we get that full reimbursement, that would be a huge alleviation to our concerns.
Well, thank you for sharing that. I clearly agree with you in regards to that anything that will be able to assist in this regard, we definitely have to push for it. Mr. Chair, just in closing, I have just two more questions quickly, if I may.
Proceed.
In regards to operation expenses, I saw in your testimony that there's a decrease of 1.3 million, which is pretty good. So I'm interested, what do you attribute that decrease in the operation expenses? And then in your accounts payable, I see you have you've done a great job in bringing that amount down, which is now the current amount you have is around 13 million. What's the plan to make good to that payment?
I will defer to my CFO on those two questions.
So as far as reducing expenses, that includes everything from folks watching their overtime, which the nursing leadership is very engaged in, all the way we have in-house legal who is terrific at helping us review contracts. She just termed one for us that we found out we'd no longer need it, and that'll be like $92,000 for next year just in that one contract. So it is a variety of things. It's just everybody blocking and tackling, and each department is going through, and there's a great sense of investment in there and to watch those expenses every day. So it's not just one thing, it's initiatives all over, and we are tracking those too to show the successes of those.
I want to dovetail on that as well. As I mentioned in my testimony, one of the things that we've been training for quite some time now and are getting ready to implement with the turn of the fiscal year is departmental budgeting. So we are putting the ownership on the heads of each department. Every single department in the hospital is going to have their budget to take ownership of. They're going to have to respect the budget they're given or that's decided upon, and variances will have to be explained. But having, I think, the entire team to have eyes on the budget is going to create and bring the success, and that's been a huge initiative this leadership team has pushed.
You had one more question?
I'm glad to, no, that's good. I'm glad to hear that. It clearly shows a difference between our hospital on St. Croix, one at Lewis, which does not include the departments and divisions within their budgeting process, and what you guys are doing over there. So I commend you, and I hope that the leadership is listening this morning. Thank you, Mr. Chair.
Thank you, Senator Carrion. Dr. Gallagher, you are projecting $49,840,000 this year, which I think you're going to meet because you're at 32, so that's like 16 million every 4 months. So next 16, you'll be pretty close. And I know that you're ramping up collection. But next year, you have ambitious numbers, 58,600,000. How are you going to increase by some 9 million? I want you to. I just want you to explain.
And I'm a little bit conservative on some of the numbers, but we do have the charge capture initiative I explained before.
Okay.
And then we have the physician buy-in. We cannot do this. Folks were not willing to do this. So we have that, and that's about $800,000 just based on our numbers, you know. And then we have $200,000 for infusion and injections once we get all that documented and charged correctly. So that right there is over $1 million. With a couple of small initiatives in there. We're also renegotiating with contracts, and they love Dr. Amaro, so they like having a physician at head. So we're in the throes of that. We want to actually celebrate that in September. We haven't gotten all those things in place yet, but we're renegotiating our payer contracts, and they want to help us keep things on island and things like that. So it's pretty exciting that some of those things, and again, expanded services, again, and make sure we bill and collect. One of the things they did here, I'm probably going. But anyway, the cardiology, interventional cardiology just occurred. It was a planning meeting where they wanted to make sure they captured everything first. We had everything in the charge master. So that was kind of nice. And then we're having a follow-up. The VP of Operations can't wait till we get back so we can do a follow-up. What was charged? When are we going to bill it, like within those days? And then what are we going to get it? Just like the total joints. So with everybody doing that, it really is achievable.
Okay. Are you going to be doing stents in your cardiology?
Yes, that's the intention. We're starting off light. We had our first go. They're coming intermittently right now as we get our processes together again with staff and challenges and some other concerns. And one of the things we need to have a new cath lab. But our intentions is at the turn of the year we would be able to be advancing into 24/7 services. But absolutely, when they are here, certainly we're going to be entertaining cardiac stents, you know,
Okay.
taking care of an acute MI and so forth.
So you are able to hire an intervention cardiologist?
We have contracted with interventional cardiologists out of state, partly local. It's the same interventional cardiologist. It's the lead, because it's a group. So the lead is an interventional cardiologist that was working with us when we had services before the pandemic. He has enlisted another local provider, another local interventional cardiologist that we're very familiar with, as well as others in the group that's going to do a rotating service here on an intermittent basis. And as we move forward, that's going to increase to 24/7 services.
This group is out of Georgia, Ottawa State. Georgia.
Yes, sir.
I figured so.
Some of the physicians are from other states, but
Yeah.
generally based in Georgia.
Okay. Are you having any joint conversations with St. Croix, any territorial conversations in reference to some of these cost-cutting measures or path moving forward that would allow the hospitals to realize increased revenue and decrease expenses?
Absolutely. I mean, we're one body, one territory. Both hospitals present and have our discussions at the territorial board level. But many of my executives are in constant conversation with many of their executives. Certainly, Dr. Gallagher has been in conversation with CFO Moorhead. We've shared notes, and we're continuing to work collegially to make sure that things are happening, in much the same way both places.
Okay, so this intervention cardiology program is similar to what they're trying to do on St. Croix. It seemed like to me the description of the group seemed to be the same group. Or you're not sure?
Quite honestly, yeah, I'm not sure what group that they're working on, so we didn't collaborate on that measure.
Okay. I like the increased revenue and decrease in expenses. That's the way to go, and at some point we'll be able to not be operating at a loss and be able to really move the hospital in the right direction where we can become a beacon of the Caribbean and individuals could be coming to the Virgin Islands for services. We must decrease, what is it? I think it's almost 50% of our insurance money that we're losing to the mainland and a large portion to South Florida.
Yeah.
So if we can get the services here, we'll be a lot better off. Senator James, you recognize.
Thank you, Mr. Chair, for the time. Good morning to the people of the U.S. Virgin Islands. The Dr. Amour and his team, I just want to say keep up the great work that you're doing, and hopefully we can reach to some point where we can deal with some of our issues when it comes to collections. But I know when Juan Louis came before us, they told us that they have a plan in place to reduce off-island patients leaving the territory. Do you have a similar plan? And if so, can you explain that to us? And how you plan to keep those revenues in the territory?
So thank you for that question, Senator James. We are a 24-hour small community hospital. There are services in this hospital we will never be able to do. Just as being on an island, 32 square mile island in the middle of the Atlantic Ocean, we don't have the volume and the population to do certain services. It would be, the government would be totally subsidizing a neurosurgeon, some other entities, a cardiothoracic surgeon, or some other entities that physicians that they really require a population of over 1 million solidly to be able to have those services here. We thrive, and we, for our small hospital and what we have, to have, if you saw in my testimony, 19 subspecialties. That is unheralded. I mean, you're just not going to be able to see that in a like population, like size. I think that's a compliment to, one, the physicians that want to be here and are really taking ownership of the community, but two, to a certain extent, the setup that we have for physician reimbursement also is very, very, and the model that we have is very unique, but it also creates a draw to have physicians come and be retained. They are the ones that's going to do the services that you're speaking of.
I really want to ask more questions. Do you think the way how the Virgin Islands government hospitals are structured, that whatever you can't get in Juan Louis, you can go to get at the Snyder Regional Medical Center? Are we duplicating efforts based on what you're seeing?
Some efforts will have to be duplicated because of the services are immediately required, like cardiology. I struggle to think that a cardiology service is going to exist just on the one island. When you have a heart attack, time is muscle, and you have to be able to get to that cath lab immediately, not wait on a helicopter. Other efforts we can share, like I don't think you need 2 cancer centers. I think that's something that we can share. So we already do what you're asking.
sure that at the end of the day, certain things, yes, do need to be in place on both islands. But instead of having to travel to Puerto Rico and Florida and all these other places, that we have two hospitals structured in a way where they complement each other when it comes to their voice. I see that you have projected $68 million in patient revenue for FY 2022. That is a $7.2 million increase from the FY 2022 unaudited patient revenue numbers. What would you say would be contributing to the increase in the $7.2 million when it comes to patient revenue?
Good question. Those are some of the initiatives we mentioned before. We're going to be capturing charges better. We're doing our charge master now to make sure we have the appropriate charges in. And there's a couple of technology tools that IT is helping us with too. Also upfront, we're verifying medical necessity so they don't get denied. So there's a variety of those, plus some expansion of services that we already have. So it's low cost investment, but there will be more revenue driven from those expanded services.
2 minutes.
Thank you for that answer. When One Week came before us, they gave us a detailed breakdown of their revenues. I'm not sure if I missed that here, but for FY 2022, I mean FY 2020, can you provide that breakdown for us, or is it somewhere in here?
No, I can provide that breakdown for you. I'll get that to you. It's on our initiative sheets, and we go through, and I do have the initiatives for the, I think it's $8.8 million increase in revenues, and I can get that to you. It's just on our internal initiative sheets. I can get that to you. I don't have it right.
Please do so, because it gives an understanding on the areas that needs more focus, and if it needs more staffing and attention, it gives us an idea of how you're doing overall as far as your patient revenues. Because I know one of the things that Juan Louis is working on is their operating rooms. How many operating rooms do you have at the Snyder Regional Medical Center?
We have, well, total, I think we have like 8 operating rooms, but we have 4 operating rooms that are that we utilize.
So 4 are down.
I'm sorry?
So 4 out of the 8 are not in use.
We actually, I stand corrected. So we have 4 in our OR and 1 in the labor and delivery department. So 5 are in use, yes.
And the remaining 3, what is the status of those?
Good morning, Senator. This is Mr. Smalls. In the labor and delivery area, we're only utilizing 1 room. The other 2 rooms, well, of the 2 that remain, 1 would be available if need be. So really, technically, we only have 2 OR theaters that are down that are not usable currently for operating procedures.
And I'll add that really the limitation is not so much on the facilities, is of course staffing.
Okay, because I know in 1 week for us, they were able to break down how many operating rooms they have, the kind of revenues they're expecting from the operating rooms, and I wanted to see something similar when it comes to the Snyder Regional Medical Center, so we can have an idea of the revenues.
Time.
Speak about the budget. We want to make sure that you are generating revenues, and we have a sense of understanding of where the revenues are coming for each operating room. So do you have that breakdown for the revenues for each operating rooms?
Certainly, we can produce that. It's a moving target. Again, understand that just opening an operating room doesn't give the whole picture. You know, patient volumes and makes a big difference. Understanding that from those volumes, 75% of that is underpayment. So you have to strike the right balance in that you're not really just opening operating rooms. You have to keep the operating rooms filled and flowing. That becomes a challenge when you have competing entities outside of the hospital with their own operating rooms.
Time.
And Mr. Chair, let us ask this one last question regarding the
Yes, sir, ma'am.
unit at the Snyder Regional Medical Center. I want to know what is the current status of the dialysis unit, and if there are any upgrades expected, what are the challenges do you have there, if any?
So the current status, our dialysis room is active, it's open. We have a census of 68. Certainly we need to have more dialysis chairs opened, but that's limited again by staffing and the ability to staff more chairs, because we do have more patients receiving dialysis outside of the outpatient arena who come to the emergency room just to get their dialysis means, because we don't have the staffing to be able to open more chairs at this time. We are actually limited more so by dialysis technicians, but if we wanted to, say, go to 80 chairs, we're definitely going to need more nurses, more technicians to be able to do that. Nevertheless, we just passed a reaccreditation with Joint Commission for our dialysis unit. We are accredited. The team is a very strong team with a very strong leader, and continues to provide the dialysis provisions even at a cost or as a loss leader to the organization.
Thank you, Mr. Chair, for the time, Mr. Dr. Amaro and his team. I'm hoping and praying that you meet your expectations when it comes to the patient revenues, and we will continue to monitor the situation down there at the Snyder Regional Medical Center to make sure that Virgin Islanders do have a better quality of life. Thank you, Mr. Chair, for the time.
Thank you, Senator James. I just wanted to put on the record, because we always have, healthcare is big in any territory or any jurisdiction. For the Virgin Islands to improve our healthcare, I'm sure I need to go away and study and come back home. Or we're forever going to be recruiting individuals from the mainland. To have 8 operating rooms functioning at the same time, you need surgical teams, you need surgeons, there's a lot that you need besides the facility. You must have surgical teams. We have 4 operating rooms in St. Croix. We have 1 surgical team. So in reality, it's only 1 operating room that we're using. You need surgical techs, etc. Dialysis, the same thing. Every single thing that we're talking about in this community as it relates to disaster recovery, engineers, accountants, doctors, nurses, has to do with our capacity to motivate and encourage individuals to go into these areas and return home. We can't have 100 applicants to be a flag waver on the side of the road, and 1 applicant to be a nurse, 1 applicant to be an accountant. And that's the reality. We keep on saying, oh, we bringing in too many individuals, but we have to motivate our children to move into these areas and for them to return home. Dr. Amaro is a local, and I must have a local at the helm. We're lucky that he has returned home. Engineer Smahouse is a local. He has returned home, but we have to be able to motivate our children to go into to these fields of math and science, and not everybody expect a government job without the requisite qualifications, etc. Because we create a bunch of exempt positions for individuals who do not have the requisite know-how or experience, and we give them these jobs at $75,000, $85,000, and then we begin to wonder why the Virgin Islands have issues. We have issues because we have to give people that don't have capacity that campaign for your job. And we need to switch it, that we are going to be employing individuals that have capacity. That's why I asked Dr. Gallagher, well, what's your background? I don't know we're paying her a nice piece of money, but she has to come with background, and she must bring something to the table that she can deliver to the community of St. Thomas in order for us to hire her. And we got to move in that direction. We can't hire by friendship and cousin and all type of stuff. We got to hire by capacity to move these institutions forward. We got to do that. If we don't do that, the Virgin Islands is going to be doomed forever. It doesn't make a difference how much federal funds we have. If we are not going to hire based on capacity and not on friendship and who campaign for you, we ain't going no place. Senator Potter.
Thank you very much, Mr. Chair. I echo your sentiments. Morning, Dr. Amaro, to you and your team. I very rarely do, and I haven't been in this business for a long time, but very rarely do I come to a budget hearing where you feel a sense of hope and encouragement that things are not perfect, but on the right track. So when things are on the wrong track, the leadership gets the blows. And when things are on the right track, I think leadership should get the credit. And so that speaks to you, your leadership team, and the staff and management of the Roy Schneider Hospital. Dr. Amaro, how long have you been serving as interim CEO?
Since February of 2020.
February of 2020. Yeah. I'm concerned, and you didn't put me up to this, but I'm concerned that at least from my perspective, it doesn't seem to be a priority to permanently fill this post. Obviously, my vote, which I have none, would be to put you at the helm just based on your track record. But I think in periods of instability and turmoil and emergency, you need stability at the top. And I mean, it may not be affecting the way that you're performing because you're doing a stellar job, but I think that the board ought to prioritize filling this vacancy and not just taking things for granted, which I've had a conversation with them, but from my outside vision looking in, it seems as though they may be taking things for granted. But you don't have to respond to that. Dr. Amara, there is a decrease, according to the post-audit report, in physician fees from $3.5 million in 2020 to $2.5 million in 2022. What are physician fees? Is the decrease a good thing? Is it a bad thing from the hospital's perspective?
So the way, thank you, sir, Senator Potter, the way that's categorized, the physician fees are really relating to the locums, to the temporary physicians that we bring in. And so it's a good thing in the sense of that we've converted more to more permanent physicians. What you're seeing is the ER conversion where we are now, and proud to really state that we are fully staffed in our emergency room with all the physicians that we had positions for. That creates a cost crunch, because, those are local physicians. They're all getting GERS benefits. I've spoken on what that is to the organization, but what it does is it creates a quality, it creates an ownership of the ER from physicians that are now ours, and it's not in and out. So those physician fees actually went down because we're really not bringing in locums anymore, or very rarely to maybe support vacations and so forth.
Okay, excellent. How many employees do you have at Roy Lester Schneider right now? And what's the average patient census?
We currently have 559 FTEs.
Okay, okay.
The average
patient census.
Average patient census has been 60 the past. We watch that twice a day. I do. They watch it a lot more than me. And that includes babies and things like that. But we watch it. And if you ever want to see a nice thing, and we can send you this, it breaks it down by unit and tells you how filled the units are. So, but they run about 60. And again, staffing is they do an amazing job with what they have.
Okay.
But if you like to see how they track it, I think it's really cool.
Okay, excellent. How many, and I know many hospitals, there's a relationship between the census and the number of employees. And when the census is down, usually since revenues are really brought in theory, by those persons, the patients, and do you subscribe to that sort of model, that sort of approach, as far as that relationship?
2 minutes. So, Senator Potter, I believe what you're referring to is the ability to fluctuate or flex our staff based on the census. As mentioned, we have 9 collective bargaining agreements, and as you can imagine, we're bound to certain terms. Some of those agreements require us to offer guaranteed hours, 80 hours a pay period. So even though we have, low census, we're still required to offer employees, particularly our full-time employees, the same amount of hours. So we're unable to, as best models will suggest, that you fluctuate staffing based on your operations, we are unable to do that.
And that's I will add to that when we talk about the many intricate details of challenges that we face that like hospitals in the United States do not face, this is one of them, being very, I don't want to say burdened. I mean, the union has its place and its position, but there are challenges it creates for us, and that's one of them. We can have a census of 100 with the same staffing level. We can have a census of 10 of patients, and we're still paying the same. We are unable to flex. There's also no pool of nurses on the island to be able to pull from if we needed to go up. And if we needed to go down, there's nowhere else for that staff to go to for them to be made whole. So it's a very, very complicated challenge.
And those are some of the unique challenges that people don't really pay attention to, that you must experience. Now, with regards to Kimmelman Center, is there any have you ever thought about the idea of partnering with a nationally renowned cancer center to help run the Charlotte Kimmelman Center when it's up and running once again in the next, I don't know when that'll be, in the next couple of years?
Thank
Is
you
there
for
value
that.
in that?
Thank you for that. I mean, we continue to hold communication and partnerships with, we have radiation oncologists that has been part of the mix from Puerto Rico. We have relationships and so forth. I must say we have an excellent administrator. My own executive, Attorney Comisión, is over the Cancer Institute. She has excellent communication with many entities outside of the Charlotte Kimmelman Cancer Center. But I think we do a great job. If there are any fallbacks as it relates to it, it's over the situations that I have mentioned before, the way that we get paid in the TEFRA-based system. We don't get the reimbursement for high-cost drugs like chemotherapy and that sort of stuff, so we lose there. Radiation oncology has done pretty well. We want to return that. But if we just do a couple fixes, i.e. 340B programs to pay for those drugs, or the relationship with Medicaid to pay for drugs ahead of time to the patients, and it's not a cost incurred by the organization, we'll be just fine.
Time.
If I may, Mr. Chair, I noticed in the post-audit analysis that when I looked at salaries, and I saw a range for staff, physicians from like $87,165 to $425,000. So I was just curious. Help me to understand the rationale for such a wide range.
Sure. I mean, excellent question. So our physicians are part of two different unions. One is the ER. We talked about that, and we got the ER piece done. The other one is AHEP. And within AHEP, there are a number of physicians in that union that go by union scale. So upon entry, they are receiving that first step, which would be around the 87,000. But then you have a set of physicians that are not unionized, i.e., or for instance, anesthesiology. They're not in the union. So where's the difference? For the unionized physicians, they receive more like a stipend is what you really are seeing with that 80 to 90 to 100,000. Okay. It's really to cover their call, where they take call for the organization and meet that responsibility. They are able to bill on their own the patients separately. I know this upsets a lot of patients because they see a separate bill coming from the physician and they think that their total bill from the hospital encompasses the physician. Not for those physicians. They're able to bill separately and able to collect the balance of what is not seen by that small salary. The physicians that are not in a union, such as the anesthesiologists, they are paid a full salary. So when you see that 400,000 or whatever, that's actually appreciating a 50 to 75th percentile salary of their full salary. They don't bill. The organization would bill everything at that point. But that's where you see a really large discrepancy in those salaries. It just depends on what category they're in.
Okay, I got you. My final question, well, not a question, but a comment on the oxygen generator. I think that was just a very, very good move on the part of the hospital management. I know something that you become conscious of in the COVID era. I remember seeing news reports where persons in India and countries, various countries, who were dying basically because of the lack of oxygen. So to say that we have the ability to generate our own oxygen right now is a comforting thing. So thank you very much for all that you do. Thank you very much, Mr. Chair, for the time.
Thank you, Senator Bata. The physician compensation package we use is pretty unique to the Virgin Islands, though.
It is, and have it exist and be maintained. It is part of what is, a very lucrative draw. If we didn't have that package, I can say that we would be, without many, many services and having to incur the expense of shipping a lot of folks out.
Do you believe, and I'm just asking for your opinion, because eventually a bill is going to come to the floor that addresses this particular area, which is medical malpractice. Do you believe that we should continue with Department of Health having this self-insurance policy that goes through Department of Justice and we're not actually engaged in the insurance market, or should it now become a requirement that medical practitioners have to purchase malpractice insurance?
So, I'm going to answer part of this. I'm going to actually enlist Attorney Commission into this answer as well. All encompassing, these are some of the benefits that have drawn and kept physicians on the island. Being able to have a low cap, being able to have a system of malpractice insurance that is not costly to as compared to the States becomes a draw. You try to figure out, why would a physician want to come to work here?
Right, but the malpractice policy is costly to the GVI because they only take one case, one settled case at $250,000 to wipe out all of the premiums that were paid for that particular year.
Someone has to foot the bill, so what would the corollary be? You would raise the rates, detract physicians, and then you don't have physicians, you don't have the malpractice, but then you don't have physicians either. I mean, that there's a balance there. I think the technology aspect of things within their scope, within their comfort level, but they have become so well trained and versed to be able to do those things because they live on this island, they know our needs, that now they're entertaining and entering into things that normally with the malpractices, you won't ever even entertain. Given what they have to entertain here, these are the things that attract and keep physicians here. And it's a really, really fragile glass to stand on. You go messing with it, and then you know the results of that.
Should that luxury hospitals adapt to private providers that are not working at the hospital? Because there's a clause where you have a private practice, you're not working at the hospital, you can pay into the self-insurance, and then the government still foots the bill. Should it just be applicable to the hospitals and the FQHC?
So, very good question. I think it's a draw to work in the hospital, and I like that aspect of it. I mean, I'm a community physician as well.
If we do it for the hospital, would there be opposition if we exclude individuals who don't work for the hospital?
I'm sure.
Okay. I'm just trying to know, because we must have a discussion because it's working on one end, but on the next end it's not working. And then to a certain degree, when you have a private malpractice insurance, it keeps you on your toes because if you make mistakes, the premium increase. The way that our policy is written, it erases your mistake. So you always have a fresh slate. So there's no need for you to worry about correcting or being more careful. It's always going to disappear once there's a settlement. So would there be opposition to change that you don't erase that particular blemish on your record, and that we develop a different, more comprehensive approach as to where, after a certain amount of those notch on your record, that you would have to foot a certain portion of the bill. I'm just thinking overall about how do we force individuals to be more accountable. I mean, we have some doctors that not an issue, and we have doctors that had 15, 20 malpractice areas in a short period of time.
But realize, sir, that aside from the malpractice itself, the National Practitioner Data Bank records and maintains these errors, these payouts, whatever the infractions may be, and that retains within their record. So there is some level of accountability they have to take into account.
But do we report that to the National Registry?
Yes, we do.
Okay. Senator Sarro.
Morning to all. Morning again. Well, afternoon or morning. Still is morning. Based on your budget appropriation, what's your actual? What have you spent so far? Over 25 million.
Oh, from the 25 million. I will defer to my CFO.
You have
As of this quarter, what's your actuals?
We spent everything. We have 2 more appropriations coming, so we've spent it all.
You spent your 25 million
21.
appropriation?
No, we still have 2 more come. They do allow it on a monthly basis.
Oh, okay.
And 275 goes to WAPA directly, and then we pay, payroll and other expenses for the rest.
Got it. Who is advocating for the TEFRA rebase to be adjusted? Because every testimony, TEFRA rebase is in a testimony. Since Noah's Ark was built, what's the discussion with the Congresswoman?
So I will admit that I need to have more discussion with Congresswoman. I haven't had the opportunity to grab her ear yet, and I certainly want to put that as one of the things I would like to do. But
that should be a discussion in direct alignment with the MAP discussions. To be honest, if when we had the air of Congress fighting for that whole that change in MAP that went to 100% and then came back down to I think 23%. I think it was 70 something to.
Well, right now we're at 89%.
Oh, 89%. Okay, I knew it was something, and that's good. That needed to be at the heart of the discussion. That MAP and the TEFRA rebasing remains an issue for both hospitals.
That is correct. That is correct.
Because it is a budget issue. You continue to have a shortfall, and Dr. Pamela. Tell me last name.
Gallagher.
Pamela's good.
Okay, Pamela's good. Okay. That's a budget issue. You could see more money in the coffers and be able to do, because frankly, the government of the Virgin Islands, the coffers are tight.
Right.
We have a whole GRS looming situation that it's like you're balancing between GRS fixing schools, hospital, roads, and we see the umbrella issue and everybody comes, I need this, I need that, but we have to, as policymakers, balance, when we're cooking food for the children, you have to ration so everybody could eat. And that's what it comes down to. So you promised me a discussion with the delegate, right?
That is right.
Okay, and lobby some Congress people too in the process. And
Yes,
if you need this body to, help you lobby, we're here to assist you. ER, fast track system. Where are we?
So the fast track.
Because I sit in your ER with torn ligaments when I had knee reconstructive surgery for quite some time. Painful.
Yeah.
Tell me about the fast track system.
The fast track system right now has been fortunately and unfortunately, it was converted to a COVID triage unit. So we don't have that unit really in relation to fast tracked anymore.
So can we link it to, I remember in speaking with the Department of Health, you talked about physicians 2 seconds ago, and attracting physicians. And part of that whole loan repayment process and receiving some of those benefits to attract physicians was the need for the hospital to have the fast track. So with losing the fast track to COVID, you're losing the ability to make an attractive package for physicians. Is it safe to make that correlation?
Previously, but we don't. That package is no longer available. They don't see. This was a long conversation I had with the health service core. Was why is the emergency room, because they don't provide those subsidies for inpatient status. The emergency room really is not an inpatient status by by how we bill and so forth. But they see it as part of the hospital. So only the fast track was what they considered to be an outpatient status, not even the entire emergency room. But that I don't think exists anymore, even for the fast track. So yes, if it was existing, the pandemic and the COVID and the response that we had to make for that would have eliminated that ability.
So let me go to your locums and what do you spend? I was trying to scrub the post-study report and see what do you spend on locums?
Well, I'm proud to say we don't have any locums in the emergency room anymore. We're fully staffed.
That's beautiful. Since when? When did that?
We signed everyone as of November 2020.
So tell me what that savings is then. What's the savings on that? CFO?
Yes, we have right now, and we have to take all the locums together, so I took them out, was $794,000.
So we're saving 794?
But remember, some of that went into salaries, so it's like an offset.
Oh, offset.
And that does not include travel and things like that, because once they're employed, we also reduce those expenses.
So
1 minute.
are you able to do a true up at some point just so we can see what that savings is?
Yes, and Dr. Penn has asked for that already, so we're in process of getting that for her, so
Beautiful.
sure you get it.
Okay, let's go to your salary negotiations for nurses. Are we up to, are they on, Ms. Mason, are they on the right step? What's happening?
So the Office of Collective Bargaining has already reached out to us and soliciting dates when we can get together to do the VISNA negotiations. We are almost at the end of fiscal year 21. So if it doesn't happen at the end of this fiscal year, it will be very early in fiscal year 22. At that point, the salaries for the nurses, they will be moved to step, and any additional increases that are due based on the negotiated salaries will be implemented. And as was referenced earlier, I also wanted to share that just in general terms, as we look at what's happening nationwide, we're also considering what we can do internally for our nurses at this point in time.
Do you hire agencies?
We currently have 8 registered nurses who are on agency.
Okay.
Time.
Mr. Chair, one more question. I need to go to my friend at the end now, Mr. Smalls. I don't know if it was discussed earlier. I had a very critical meeting I had to run off to. The hospital, remember we were waiting for FEMA to give us a decision on whether or not it should be rebuilt. What's the status? I'm just seeing this. Is it in this testimony?
It's partially in that testimony, yes.
Okay.
Where we're at, we're still in the discussion, negotiation with FEMA as it relates specifically to the Roy L. Schneider Hospital, trying to arrive at a dollar figure of the damages, the estimated costs for bringing it up to codes and standards and pre-existing conditions. One of the major challenges that we've had is a lot of the temporary repairs that we made to the facility has been considered as permanent repairs, whereas we know they are not permanent, they were temporary repairs. To this date, we still do not have a roof on the facility, so I try to explain to them on a regular basis, when they come in and they look at ceiling tiles, they look at lights, we have to do that. We have to make the environment safe for our patients, but at the same time, the roof is still a Band-Aid.
So, Mr. Chair, I'm begging you, please. Let's go back a second. So we have all the heaters working, all the chillers working?
Right now, yes.
All 4? The boilers, all the boilers?
2 boilers. We have about 4 water heaters.
So
we have 5
at one point
chillers.
we had 4 boilers, right?
No.
2?
It was only 2 boilers.
Okay, and the tour you took me in the back and we had 4 big stuff.
Oh, you were looking at the tanks, the water tanks.
Oh, okay. Everything's working back there?
Yes.
In a little area?
Yes.
Okay. So you can't say that right now, right? What would the projected cost be to rebuild the hospital? Is that private information?
It's not necessarily private information. If we just want to look at from an industry standpoint, we're at 250,000, just over a 200,000 square foot facility. I have a colleague in the mainland that is building a new facility, and we're looking at over $1,000 a square foot. So you do the math, that is a huge sum. Fortunately for us, I think we have the opportunity, not necessarily from building from ground up, you have the ability to do a total reconstruction.
Wing to wing, the whole wing?
Wing to wing approach, which has some savings, but yet at the same time, at the end of the day, the costs are almost going to come out to the same. What you save on really, though, is the time to be able to construct.
Thank you. Thank you, Mr. Chair.
Thank you, Senator Sarong. So with the Kimmelman reconstruction, you're not necessarily going with a full demolition. You're going to keep the walls that are good and change the windows and interior, et cetera, correct?
That is correct, Senator.
Okay. And that would be a lot quicker than having to go through a full demolition.
As it relates specifically to that cancer center, knowing what went into the construction, yes, that would save a considerable amount of time.
Okay. And that's an important component for us to be able to get back for the Virgin Islands, because a lot of individuals, they really don't have any way to go. So those individuals that don't have the capacity to go to the mainland and stay with a family member for extended period of time, they end up staying here. and that we finally getting somewhere with the Killerman Center, and I hope that we can get it expedited as quick as possible. I know that oncology is one of the areas that the hospital loses a considerable amount of revenue, correct? Because of the cost of the chemotherapy drugs and all of that?
That is correct, sir.
Okay. So that's one of the areas we don't have a choice but to subsidize because it's a service that we need. So it's something that we have to do. How much of a deterrent is this GRS conversation that you continue to have?
You know, my mom is a retiree, so I know the importance of it, so I temper my response based
And that's what I wanted to ask. I don't know, yeah. I mean, I see both the discussion between Snyder and the discussion also with Wang Louis, you know, that it is a deterrent, 11.5%. The bigger deterrent is going to be if we don't pay any money into the system and it collapses.
Yeah,
you know, and the code just states that you come into work for the government of the Virgin Islands, you must pay into the retirement system. And I don't really think it's one of those negotiable items. You know, it's hard for us to take that off the plate unless we have this large infusion of cash that we're going to be able to take care of the 9,000 Tier 1 employees that have retired. And
yeah, it's you know, it is really difficult,
yes.
but we cannot understate, and my executive director of human resources, Ms. Mason, can talk your head off about this, you know, as well as everyone that hires anyone in the hospital or I guess anywhere else. You just can't understate what a deterrent it is. I mean, despite the need, you know, of everything you just stated, which is very accurate, and like I said, she's the greatest woman in my life. I want her to be able to get her retirement funds. But it causes an issue. We've had people look at it and said, you've got to be kidding me. I'm not signing here, giving 11.5% of my money into something that they don't even know is going to be solvent. Yeah, and even if it was, they still don't want to sign and give away that much money. So the facts are just what it is. It's a deterrent.
And it is, but the flip is you can have your own private retirement account and it goes belly up. And they could be depositing money into that program forever, and the market tanks, and the money is gone.
Usually that would be at about 3 to 5%. I mean, it's you know, so the two facts I stated in my testimony, of course, is either they don't sign or they wait till the 9th year to get out and not become vested, because it's you know, it is a deterrent, Ms. Mason.
So what I would add, Senator, is with 11, what we try to do with our salaries is mirror what the rest of the world is doing nationally with the same qualifications. How will I match an equal candidate? And what's not contemplated in that is an 11% deduction.
Right.
So when I offer a salary, if I say, when I look nationwide, your salary is $70,000, and I offer that same thing to someone, and they will be all ready to come until they realize that off the top of that salary is going to come 11.5%. And then you start factoring in, cost of living, housing, and all the rest of that. And immediately,
it pays to live in paradise.
Immediately, the idea of living in paradise goes.
And when they're doing all of that cost and the head beginning to hurt them, just let them catch a ferry, go to St. John, go to Cinnamon Bay, buy a 6-pack of Heineken, and they'll forget about the 11%
and at the end of
and
the
work
day,
in the Virgin Islands. It's the greatest place to live and work. It's beauty. I mean,
at the end of the day, it comes down to the bottom line.
Okay.
Yes.
Dollars and cents.
But we're seeing progress, and we need progress. We need a change. So we thank you for your testimony point of inquiry. Senator Sayo.
Thank you. I didn't get to, this is in my notes, dialysis. What's the future of dialysis?
Thank you. Very good question.
And your head nurse, Monique, is good, by the way. Just need to shout her out for that. I have a few dialysis family members, so good members that do that.
No, she's part of that team. Like I said, this team did, surpassing benchmarks and Ms. Hodge and Monique and the entire team, all of those guys relentlessly work, short staffs a lot of times and so forth to provide the care to the Virgin Islands. So dialysis, again, complex, because while we are short staffed for what we have, there are not enough dialysis patients in the entire territory to divide up among 3 or 4 dialysis entities and bill and be able to survive. So it's usually, for the most part, going to be a loss leader in the cost of supplies and shipping those supplies and the cost of, in everything, staff is on top, the cost of staff and being able to get the staff. The challenge, I want to say that for dialysis, we are always going to need it and we're always going to have it. How well it's going to survive and how much, it's going to survive. It's always going to be there. The hospital will always be there and dialysis will all be there. But how much it drains the hospital's resources financially, how much it causes us to come before you and say, listen, despite all these projections, here's this loss leader that's taking it away. That is the untold factor moving forward, because we have to figure out how do we resolve the billing component, being able to, we really need to do a lot more preemptively to have people not go to dialysis, meaning, education and training and that sort of stuff, so that they can take care of themselves, don't lose their kidneys and have to end up on dialysis. But for those that do require
let me
it,
ask, what is the cost in the hospital right now? Because it seems to Dr. Pam.
The cost varies because it depends on how many treatments you have. Most folks will have 3 per week and things like that. But the thing that's really hurts us is the revenue coming in for that. Medicare pays $2,700 a month for most patients. When you do that 3 times a week, it's on a recurring basis. So that's not a whole lot of money. So the costs are definitely, now the U.S. Virgin Islands government is helping us offset that with that $26.75 million. So you're helping compensate that. But if that program grows, there'll be more to compensate for. So each one, and it varieties, like we were just doing a cost analysis, and it ranges. Some people need different, tubing and things like that. The nurses are really and we'll have a more concise answer for you. We're meeting with the nurses, and the first thing they want to know, making sure they're capturing the things, making sure they're using the proper equipment. But it varies. Like they said, I want it to be, $5.95. It's, $150 per visit for one person, and it's only like $39 for another, depending what services they need. It's specific. But right now, it's nowhere covering the cost.
I'll let the chair, I have a million more questions on the cost of dialysis, but I'll let the chair, I'm sure he's going to follow up on that.
The dialysis conversation gives me a headache.
Mm-hmm.
A big headache. I'll go to Senator Blyden.
Thank you, Mr. Chair. VP Smalls, these have 2 inquiries. One to VP Smalls and I guess Dr. Morrow. You mentioned the testimony of the biomedical engineering team, and you referenced Mr. Jean-Baptiste in particular, and you say it has resulted in significant cost savings. What would you value that cost savings at in terms of dollars and cents? That's the first question.
I mean, we could, he's been with us for a number of years. You couldn't really even put a dollar value. I mean, certainly we could say, okay, he fixed this machine, he fixed that machine, and that may give you something. That doesn't even really entertain the value that him and his team provides in the efficiency, the quality, the ownership, in being able to get these things turned around on an island that for those things, you have to get that off island. Otherwise, it's not like you're going to go down the road and get someone else to do it. So it would be a disservice, I think, to be able to even put a dollar value to what that department offers in our capital equipment repairs.
Okay, very well.
If I can, just to piggyback, what we're basically saying is Mr. Jean-Baptiste and his team, because they become certified on certain pieces of equipment, typically we would have to have a service agreement with a particular vendor. We can offset that cost because they're trained. We could bring that maintenance in-house.
Understood. And VP Smalls, this also spoke to capital improvements and not being able to budget for that because of the vast amount of improvements needed. What would you price that based on analysis, what would that price look like? What would our total cost be in terms of capital improvements?
I don't think I could come up with a cost, but just to put things in perspective. Typically, when you build a brand new building, a building costs $100 million. Within 5 to 10 years of that construction, your maintenance budget should be 10% or close to 10% of that $100 million, to put things in perspective.
And finally, the gift card that was done by the board, a brilliant idea. I feel it has made a big difference. Something so simple, you know, so stuff like that outside the box thinking makes sense, and I appreciate everything you guys have done thus far. Thank you so much, Mr. Chair.
Thank you. Any judgments against the hospital? Any outstanding judgments?
I will defer to Attorney Tina Commission.
Good afternoon, Attorney Tina Commission for China Regional. We have one significant outstanding judgment which we report. It's in the post-audit report too, I believe, for Royce Construction Inc. And the other settlements are being handled appropriately for both medical malpractice and our civil cases.
Okay, the one for Royce Construction is what I'm trying to remember the amount. What's the amount?
It was approximately $1.7 million at the time of the judgment.
Okay, and also work that was completed but never paid for?
That was work associated with the original construction of the Charlotte Kimmelman Cancer Institute.
Okay. Okay, thank you so much. Dr. Amara, I'm going to allow you to put a closing statement on the record. I want to thank you for your testimony before this committee today.
Thank you very much, Chairman VLA and members of the 34th Legislature. I do sincerely thank you for allowing us to testify on the 2022 budget for SRMC. We consider it an honor to collaborate on all the measures concerning the acute health care for the people of the Virgin Islands. We acknowledge the hard work and diligence that the members of this committee have put forth in addressing and securing the territory's financial concerns. In that light, we ask that the committee continue to prioritize our territory's health needs as a priority during this terrifying pandemic. No other time has it been more important to bolster the main armed forces in countering this germ warfare. We appreciate your astute wisdom in knowing the importance in securing the financial means of the flagship of health in the Virgin Islands. I would also like to take this opportunity to thank my excellent staff at SRMC. They are the reason we succeed. They reside as a testament that truly, within SRMC, heroes are walking through our halls. I acknowledge my absolutely phenomenal team of senior executive leaders who I have the pleasure of leading this organization with. Through thick and thin, we are a team that demonstrates the essence of transformational leaders. Finally, I thank my left and my right hands, Karen Rennie and Hyacinth Joseph, without whom none of my progress would be possible. Much love to all my SRMC family as we continue our strive for excellence as a high reliability organization. Thank you.
Thank you, Dr. Amaro. The Committee of Finance will recess for 5 minutes. The Committee of Finance is back on the record. Madam Clerk, can you read the next item on the agenda?
St. Thomas East End Medical Center. Invited testifiers, Molito A. Smith Jr., Executive Director.
Thank you, Madam Clerk. So, Smith, I'm going to allow you to put your name and title on the record, and then I'll allow the members that are here with you to put the name and title on the record. So beginning with you.
Good morning, everyone. Molito A. Smith Jr., Executive Director, St. Thomas East End Medical Center Corporation.
Thank you. Next.
Renee Crawford. Good morning. Renee Crawford, Executive Assistant for Policy and Administration.
Thank you. Next, sir.
Good morning, Dr. Zenma Servi, Director of Behavioral Health.
Thank you. Next, ma'am.
Good afternoon. Francia Brin, Chairperson of the Board of Directors, East End Medical Center Corporation.
Thank you. Now, those individuals that are taking part virtually, Mr. Baines.
Good morning.
Okay.
Eric Baines, Business Office Director.
Dr. Molinar. Unmute your device, Doc.
I'm sorry about that. Dr. Lucien Molinar, Dental Director.
Okay, you're going to have to get closer and speak up a little bit, Dr. Molinar, but we heard you. Ms. Dorset.
Good afternoon, Carmencita Dorset, Interim CFO.
Dr. Thomas.
Dr. Audrey Thomas, Acting Medical Director.
Ms. Webster. Take off the mute. Okay, I think you need to put back on the camera, Ms. Webster.
Good afternoon, Lisa Webster, Public Relations and Outreach.
Okay, thank you, and your camera is off. So if you ask a question, please make sure that your camera is on. All of those who are participating virtually, make sure that your device is muted. Mr. Smith, we're going to allow you to begin the testimony. I think the chairwoman, Ms. Bren, is first, right?
Correct.
So
Yes.
we'll allow her to begin, and then we'll come next to you. So you may proceed.
Good day, Honorable Senator Kurt Bailey, Chairman of the Senate Committee on Finance, and to the members of the Committee on Finance, other members of the 34th Legislature, members of the St. Thomas East End Medical Center Corporation's Board of Directors, its leadership team and other staff, patients, and others in the viewing or listening audience. I am Francia M. Brin, Chairperson of the Board of Directors of the St. Thomas East End Medical Center Corporation, known as STEAM CC. On behalf of the STEAM CC Board of Directors, I thank you for this opportunity for STEAM CC to present the Government of the Virgin Islands, GVI, fiscal year 2022 budget request and recommendations in the amount of $2,924,229. STEAM CC extends appreciation to the Office of Management and Budget, OMB, for its favorable consideration of our budget call, submission and budget recommendation in the amount of $2,924,229. We now respectfully request approval of this request by the 34th Legislature via this Committee on Finance. CMCC is a private, not-for-profit corporation organized under Title 13, Chapter 3 of the Virgin Islands Code since 2000. The only federally qualified health center in the St. Thomas, St. John district of the U.S. Virgin Islands. The organization is governed by a board of directors of between 9 and 15 members comprised of persons from across section of the community. The majority of board members utilize the health center for their health care needs as required by federal statute. At present, there are 11 members on the board. Over the past few years, the Virgin Islands community has experienced significant challenges. These include 2 Category 5 hurricanes, Irma and Maria in 2017, and the COVID-19 global pandemic from December 2019 through the present. The economic, social, and human toll of these events on our residents and the territory's previously strained healthcare environment has been significant. The loss of jobs, leading to the loss of employer-sponsored healthcare coverage, personal and physical displacement due to hurricane-related damages to homes, post-traumatic impacts from the storms and isolation and uncertainty from COVID-19 global pandemic have set in motion a constantly evolving new normal for all demographic groups. Unfortunately, the most vulnerable in our community, the elderly, children, low income, and uninsured/underinsured, are most at high risk for falling through the cracks. For these reasons, STEAM-CC is of high value in our community and a lifesaver in many instances. Over the past year, the Health Center has focused on the following initiatives: implementing a premier behavioral health program, supporting the territory's COVID-19 response while providing the highest level of protection for our workforce, reconnecting patients with care who may have been disconnected by COVID-19 restrictions or otherwise through expanded case management, expanding health promotion, education, and literacy through community outreach and engagement, implementing new approaches to hypertension and diabetes management and mitigation, strengthening organizational resiliency through workforce development, capacity building, compliance, and strategic planning. The challenges of the last year highlight the need for all of us to be vigilant about maintaining good health, managing underlying health conditions such as hypertension and other forms of heart disease, diabetes, and mental health is essential. Protecting oneself from the COVID-19 virus and its many strains is also essential. The Health Center will continue to do its part to support the territory's response to the COVID-19 global pandemic while providing life-saving preventative health care so that no one falls through the cracks. In conclusion, and on behalf of the STEAM-CC Board of Directors, I thank each member of the staff. The staff has been diligent at work throughout the challenges of the past year and more. I thank our community stakeholders, partners, and particularly the patients in our community who have chosen STEAM-CC as their health care provider. I also would like to thank the members of the U.S. Virgin Islands Legislature for their continued support of the health center's invaluable work. In the testimony which follows mine, STEAM CC's Executive Director, Molito A. Smith Jr., will provide highlights on the health center's activities, detail on the appropriation request, and a summary of priorities for the upcoming funding cycle. Approval of our appropriation request in the amount of $2,924,229 respectfully is requested. Thank you.
Thank you. Mr. Smith?
Finance Committee Chairman, Honorable Senator Kirk Viale, members of the 34th Legislature's Committee on Finance, other members of the 34th Legislature, the viewing and listening public, greetings to everyone. I am Molito A. Smith Jr., Executive Director of the St. Thomas East End Medical Center Corporation, STEAM CC. On behalf of the entire St. Thomas East End Medical Center Corporation organization, I welcome this opportunity to present the Health Center's fiscal year 2022 budget appropriation request in the amount of $2,924,229. I also extend appreciation to the Office of Management and Budget for its submission and recommendation of the full amount of CMCC's budget appropriation request for fiscal year 2022. Appearing with me in person today are the following individuals: Francia Brin, Board Chair; Renee D. Crawford, JD, Executive Assistant for Policy and Administration; J. Zen Meservey, MD, Behavioral Health Director. Appearing via Zoom video conference are the following persons: Carmencita Dorset, Interim Chief Financial Officer; Audria Thomas, MD, Acting Medical Director; Lucian A. Molinar III, DDS, Dental Director; Lisa Webster, Public Relations and Outreach Officer; Mr. Eric Baines, Business Office Director. Dr. Tess Richards is unavailable for us today, so she is not in attendance. These are extremely unique times. Throughout the world and across the region, the impact of the COVID-19 global pandemic continues to loom prominently. Since December 2019, through to this present moment, the global community has been forced to respond to a public health crisis that continues to redefine every facet of civic life: economies, schools, family life, personal and community safety, and most importantly, healthcare. Locally, particularly as STEAM CC monitors it in the St. Thomas St. John district, the impact has been a contributing factor in expanding low-income and uninsured populations seeking healthcare services. In addition to conditions related to the impact of the ongoing global pandemic health crisis, other conditions linger that continue to impact the physical and mental health and recovery of residents of all ages and backgrounds. These lingering conditions are due to two Category 5 hurricanes, Irma and Maria, which occurred in September 2017. They include the following concerns: the impact of limited or no access to services for newly unemployed, uninsured, and the elderly, especially behavioral health and case management services; the impact of being disconnected from in-person care for high numbers of patients due to physical displacement from the hurricanes and COVID-19 restrictions during calendar year 2020, and the impact of reduced access to health education and health promotion support for chronic disease management. The Health Center places high priority on tangibly addressing the needs of the community. The information below highlights some of our efforts to address these concerns and to meet the evolving needs of our community during these exceptionally unique times. Behavioral health. Transformed our behavioral health program to a standalone program, created a behavioral health wing, invested in state-of-the-art equipment and diagnostics, expanded and strengthened network of community stakeholder relations, and recruited additional therapists. Outreach and community engagement. Hypertension and diabetes control project highlighting the use of health technology. Mental health awareness, paint your feelings and mental health fair. COVID-19 care support packages for Celestino A. White Senior Home, Lutheran Social Services, Yellow Cedar, and Ebenezer Gardens, Catholic Charities, Bethlehem House and Soup Kitchen, Eldra Schulterbrand Residential Facility. Dental awareness. COVID consideration. Served as an approved vaccination site, 1,713 persons received full vaccinations as of Friday, July 16th, 2021. Participated in weekly and or bi-weekly coordination meetings with the VI Department of Health, implemented COVID-19 safety protocols pursuant to the CDC guidelines and territorial mandates, routine COVID-19 testing of staff, implemented central waiting room and intake screening center, implemented telehealth, expanded case management services. Completed 2020 community health needs assessment via the University of the Virgin Islands Caribbean Exploratory Research Center. Research. Engaged and partnered with Yale School of Medicine community-based engagement, AmeriCare's Vaccine Hesitancy Project, the HRSA National Hypertension Control Initiative, Medicaid program, implemented presumptive eligibility, pharmaceutical support, finalized our 340B discount pharmaceutical program. As the territory continues its focus on addressing the circumstances arising from the COVID-19 global pandemic since the March 2020 presidential declaration and territorial state of emergency, it is equally important to STEAM-CC that the health center does not lose focus, that a primary responsibility is to provide the delivery of preventative health care services to our residents. Throughout the pandemic, STEAM-CC has done this and more. It is essential that no one falls between the cracks. At this time, Mr. Eric Baines will read the budget overview. Mr. Baines.
Thank you for that. Good afternoon, all. This is the fiscal year 2022 budget overview and breakdown. Due to the COVID-19 pandemic, STEAM-CC continues to exercise social distancing, which includes more spacing between appointments and telemedicine via telephone. We have projected that the center will see approximately 6,923 patients with 20,769 patients visits in FY22, to include approximately 3,188 behavioral health patient visits. We respectfully request funding in the amount of our initial request to the Office of Management budget of $2,924,229 for fiscal year 2022. HIV program. Recognizing that there is severe need for services to serve HIV patients within the territory and the district, the board made a decision to use operational funds received from program income to continue providing patients HIV counseling, testing, and primary care. No funding from the local government has been specifically designated to the health center for such services. However, the continuation of this funding source remains uncertain. STEAM-CC continues to apply for HIV program funding as they become available. We also provide financial assistance to patients without insurance who qualify for our sliding scale fee discount program. For those patients who cannot afford to pay in full for services, we offer a payment plan. STEAM-CC recognizes the high cost of preventative and interventional services and realizes that many patients still struggling with being able to meet their medical and dental health obligations. Therefore, we have set aside funds to assist patients who are unable to pay for the mammograms, pap smears, prostate screening, radiographic studies, colonoscopies, transportation, and medications. I draw your attention to the pie chart for funding source for 2020, 2021, and 22. In January 2020, STEAM-CC was notified by MAP to initiate the Medical Hospital Presumptive Eligibility Program. STEAM-CC has assisted and enrolled 203 applicants in the Medicaid Hospital Presumptive Eligibility Program. Below the chart showing by month how many patients have been assisted to date. In calendar year 20, 80 patients. As of June of 2021, there's 123 patients. The next chart is a budget summary and components for fiscal year 2022. Program income is $7,539,380,000. Via government grant, $2,924,229. Federal grant, $1,294,580. Totaling $11,758,189. Budget components. Following are the categorical descriptions and budget justifications for the program cost groupings contained in the budget detail schedules, which are found at the end of this budget presentation section. Personnel salaries. Salaries of 97, which is 93 full-time and 4 part-time employees, have been budgeted at $6,206,086. Support staff is reviewed on an ongoing basis to complement provider changes. Staffing for years subsequent to 2020 will be adjusted based on these measures to ensure that appropriate staffing levels are maintained. The listing of staff supported by the total budget request by job titles is outlined on the attached staff plan. Personnel costs are anticipated to increase annually. Employee benefits. Employee benefits have been budgeted at $1,087,994 and include the benefits offered to staff to maintain a competitive employment package. The center's budgeted 2020 benefit rate is approximately 17% and is composed of the following: life, disability, and health insurance, employer FICA, or 403B, and employment insurance, workers' compensation insurance. Employee benefits are anticipated to increase by a minimum of 2% for each year. Contracts and consultants. Contracts and consultant services have been budgeted at $2,061,001. These expenditures consist of professional services such as audit, legal, incinerator, etc., in the amount of $694,110, plus the amount of $517,000 to cover medical programs such as lab, pharmaceuticals, radiology, pediatric dental, and outreach services. The balance of costs is primarily presented to provider staff, the amount of $849,891, which covers 2 OBGYN physicians, 1 part-time dentist, and 1 part-time pediatric dentist, 1 full-time psychiatric, 2 part-time psychologists, and 1 part-time pharmacist and assistants with translator and on-call services. This category is expected to experience inflationary increase 2% over the next 3 years. Supplies. Costs of supplies utilized in the course of patient care, including items used medical and dental services, laboratory reagents, and immunization supplies, have been budgeted at $703,588. Also included is non-clinical general supply costs, such as office supplies. Expected pricing increase for the next fiscal year have been included in each category. These inflationary factors range from 2% for general office supplies to 7% for pharmaceuticals. Inflation factors have been projected to continue over the next 3 years. Travel and continuing education. Cost of business-related travel has been budgeted at $37,500. This cost of approximately 27% is attributed to the administrative staff and approximately 73% to patient care staff. Examples of business purposes include educational and/or industry updates and reimbursement, patient care, quality assurance, ERISA requirements, etc. Additionally, travel costs are incurred to attend meetings of local and national industry associations. Continuing education includes the cost of the staff to attend continuing education seminars. Costs will be controlled through review of local seminars, teleconferencing, and webcasts instead of out-of-territory conferences. Equipment. The cost to cover the purchase of computers and software upgrades at $25,000. Okay, the chart below, the facility administrative and security services broken down as follows. CMCC rentals, which is space, land, and offsite storage, equates to $650,088. Communications, which is the cost of updating and upgrading in-house telephone and paging systems, answering service with provider, on-calls, and associated equipment maintenance costs. That's $200,000. Utilities, which covers water and electricity, is $230,000. And repairs and maintenance is $279,932, totaling $1,360,020. Other services. Other services have been budgeted at $237,000, including recruitment costs of $50,000 have been budgeted for recruitment. Recruitment costs include classified and journal advertisements and candidates' interview costs, page telephone listings, promotional and advertising and event costs at $70,000. Promotion expenses include patient mailings, patient newsletters, health promotion, materials and events. Health week, open house, lose weight challenge, etc. General and administrative costs are $117,000, which includes postage, shipping, events, dues and subscriptions, licenses and professional fees, printing uniforms. Insurance costs have been budgeted at $40,000 and include the cost of building contents, director's liability, valuable papers, and bond insurance. Federal Tort Claims Act coverage is utilized to minimize malpractice expense. Projected expenditures. STEAM-CC employment costs consistent with salaries and benefits along with provider salaries are the source of the largest expense outlay to the corporations, representing about 75% of all expenses incurred by the organization. It is crucial that STEAM-CC be able to continue funding these positions as they are needed to maintain high standards of care. The projected expenditures are as follows. Personnel services, $6,206,086. Fringe benefits, $1,487,994. Provider services, $849,891. Total personnel fringe benefits, provider services comes to $8,143,971. Medical programs are $517,000. Supplies, $703,588. Other services and charges, $1,033,610. Facility, $1,360,020, totaling $11,758,189. Next, we see a chart breaking down of the STEAM-CC's projected expenditures for fiscal year 2022. Okay, followed by the breakdown of program income. Net patient revenues projected from STEAM-CC's total operation include Medicaid revenue, $6,501,658. Medicare revenue, $350,882. Self-pay revenue, $254,039. Commercial insurance, $432,801. Total net patient service revenue equals $7,539,380. The center's program income is based on the anticipated yearly patient visits. While there is continued increase in patient visits, STEAM-CC's largest payer class is Medicaid, followed by self-pay. STEAM-CC recognizes the financial difficulties that some patients face and provide a sliding fee discount program, which is discounts on medical and dental and behavioral health services, laboratory radiology testing, and prescription assistance. For those that qualify, we also provide patients with a payment plan. However, for those patients who can pay, STEAM-CC continues to aggressively pursue collection and reduced age account receivables. So statistical graphs submitted to Bureau of Primary Health Care and Uniform Data Systems, UDS. You'll see the chart below, which is for the 2019, 2020, and projected calendar year 2021. As visits, you also see the patient visits breakdown for 2019, 2022, and the projected 2021 as well. CMCC requests the approval of our budget request for fiscal year 2022 in the amount of $924,229. Thank you.
In closing, I would like to summarize key priorities of the health center to support chronic disease management and the mitigation for the upcoming funding period. They are the following: completion of construction drawings and groundbreaking for our new facility, expansion of behavioral health program, expansion of community-based support services, expansion of outreach and community engagement initiatives, continued emphasis of workforce development. I take this moment to publicly say thank you to the members of the STEAM-CC Board of Directors who, as consumers of healthcare services, continue to demonstrate a commitment to serving this community. Thank you is also extended to members of the Health, Hospitals, and Human Services Committee of the 34th Legislature, other senators and their staff members who visited the health center for a tour and presentation in March of this year. Your interest in our work and support of our initiatives are greatly appreciated. Most importantly, I publicly say thank you to each member of the STEAM-CC team. You are by far the best. I continue to wish for each of you the best health, strength, and blessings as we together serve our community and navigate an ever-evolving new normal. STEAM-CC's request the approval of our budget request for FY 2020 in the amount of $2,924,229. We've included in the appendix our most recent needs assessment, which was completed at the end of 2020. At this time, I await any questions that you may have or may arise.
Thank you, CEO Smith, for your testimony and along with the testimony from your staff members. Unfortunately, I received information from OMB that the amount in the budget book was an error, which isn't good. But they are saying that the recommendation, like for Frederickston, was supposed to be the same as last fiscal year, and by error they included the amount that STEAM submitted to them. So I did have a conversation as to the path moving forward, and the recommendation was either the same or 7%, which would give you $2,033,000. So it was an error by OMB. I think they'll be sending a formal letter to STEAM in reference to that particular correction. Seeing that as a mayor, it's a budgetary hearing, so you're here to make your plea for what is needed. So we have open ears. We're willing to listen. Senator Blyden, let's do 5 minutes.
Thank you, Mr. Chair. Good afternoon again to my colleagues. Good afternoon, Director Smith, and along with your support team there. Thank you for your testimony. I saw the look on your face. I understand. We understand. Listen, let me start with the post-out report, page 4 of 12. Under other contract services, there are 2 vacant, and this is services that's provided to STEAM-CC by different individuals. There's 2 vacant vacant entry there, one for dentist and one for registered dietitian. What plans do you have to fill those two needed service spaces?
Well, we have recruited back a full-time dentist since the budget submission, and we're actively recruiting for a dietitian. But let me just state for the record that, of course, it's disappointing. We did not receive any notice prior to appearing. But this is the amount that we have requested year over year, and the needs of the community are not getting any less. And the needs are not a 7% burden over the previous year, particularly now given COVID. But I want to state on the record, you basically know our position, long-standing, so I'm not going to belabor it. But back to your question, yes, we did recruit and have on staff a full-time dentist, and we're actively recruiting a dietitian.
So at $118,497, they got the salary of that amount?
For the
dentist?
Actually, the dental salary is more than that. For the, it's higher than that. I don't have the exact number in my head, but I know it's more than the 118. Yeah,
okay.
yeah.
Okay, very well.
For a senior pediatric and adult dentist, is more than that.
Okay, very well. On your professional services, you have an entry there for Greenway Electronic Medical Records. That's the service they provide for $422,110. And it seems to be a cost share between a federal government and a local. What's the percentage in terms of the cost share?
Most of that actually is paid through our program income. It is paid from the monies we generate, and it is for our electronic health record system, all the licensure, maintenance, and so forth.
And on page 5, when it comes to your leases, I see you have monthly amounts and annual amounts, but there's no time frame. How does that work in terms of your rent?
Well, all of our leases are termed, so it's not a perpetual lease. We recently consolidated and extended our leases for space we occupy in the Tutu Park Mall.
2 minutes.
Those are 3-year with renewal options, and the other is for real property that we have for our construction.
Okay, let's go to your federal grants quickly, page 6 of 12. Okay, you have 6 entries there, and you have the budget period. There have several of them have 5 of them have expired in terms of the budget period. You have the VA government grant, which expires in September for $1.9 million. You have the technical assistance program, which expired in September, and then you have 3 others that expired, one on March the 14th, March the 31st, and April the 30th. For those 3 that have expired, have they been extended?
Well, those were time-specific grants through the CARES Act, 2020 coronavirus CARES, and those have already been fully executed and have expired.
Also, we have extended all of those funds?
No, we've expended all those funds within the time of the grant.
Okay, thank you for that, because it was not clear in the post audit report. And finally, before my time is up, let's go to your testimony, because I need to ask you a couple questions right quick. In your testimony on page 13, you spoke to the $703,588 for non-clerical supplies, How much have you spent in supplies to date out of this fiscal year?
I wouldn't have the number off the top of my head, but we can't get that to you. But I would say this. The health center has, we really expanded a lot of our services and offerings to the public tremendously. And since we are a service delivery entity, it's supported by supplies, and most of those supplies will be medical, dental supplies for treatment. There will be supplies used to conduct the compliance requirements that we have to do in terms of office and related supplies. So the utilization of those supplies is really would correspond in line with our expanded offering of services.
What would your okay? Since you can't give me that right now, what would you ask in this fiscal year for supplies? What was that number for 21?
Ms. Dorset, would you be able to answer that? If not, we'll have to get that number to you.
And Ms. Dorset, do you have the number? Okay, very well. I think.
Ms. Dorset?
I have one more question. Please unmute. Ms. Dorset, can you please unmute your device?
Sorry. Sorry about that.
Okay.
No, I don't have that information, but we can get it to you.
Okay, and in closing, Mr. Chair, Director Smith, you spoke to your aged account receivables, and you're aggressively pursuing those collections. What does that number look like right now as we speak, and how have you been faring out in terms of bringing those outstanding
Yeah, there are really two major categories of accounts receivables, which would be age accounts receivables. One would be our Medicaid, and I have to say that Medicaid over through last year the program has substantially improved. So the accounts receivable, the number would reflect about 2 months of receivables, 2.5 months of receivables, which is much improved over the 9 months or more in previous years. The other category is self-pay, and that is individuals who neither qualify for Medicaid or barely qualify for a sliding fee, don't qualify for a sliding fee. And what we have been doing in that category is really self-pay, almost no pay. So that, but we do send out statements, we do make calls, we do track them, but we're making concerted efforts to, but the fact is that that's really your uncompensated bunch.
Thank you so much for your responses, Mr. Chair. Thank you so much for the time.
Thank you, Senator Blight. And Senator Francis, you recognize?
Thank you very much, Mr. Chair, and good afternoon to everyone. Thank you to STEAM CNC for your testimony. Mr. Smith, good afternoon. How are you today?
I'm well. Good afternoon to you and colleagues on St. Croix.
Very well. So, obviously, there have been an adjustment in your budget request, and I think it's almost a little bit over $8 million, pretty close to $9 million. And I know that when the Project Health Center came before us on June the 30th, in fact, we recognize that there may have been a discrepancy in the submittal. Is it your testimony that you have not heard from OMB, or there have not been any communication in respect to modification of your budget request?
That's correct. We've had no communication either through telephone conversation or through correspondence.
Okay. And I would imagine that this is a significant decrease to what your expectation may have been.
Well, the short answer is yes, because we could only go by what is published, and when we see the publication that the amount is a certain amount, we then begin our planning based on that. But we will have to go back and look differently, and we will hope significantly that it doesn't impair the delivery of care or services to anyone. But we will make the required adjustments.
Very well. So you'll have to kind of wheel and come again, right?
The short answer is yes, but it also speaks to, I guess, a broader issue, and I think that we speak to that often when we come before the legislature, and that is, we're in a pandemic, a significant health crisis, and if there is not to be an emphasis or priority on healthcare entities that are serving the public and responding to the pandemic, and we anticipate that this is going to go on for at least another 3 years. Things aren't getting easier. It speaks to what our priorities are as leaders and policymakers, and I feel that it's very sad that we have to even be in a discussion of reducing amounts to healthcare organizations, particularly those that see a high number of vulnerable people, and support the efforts to get us to the other side of this crisis. But be that as it may, we are not going to stay here and bellyache. We'll have to do what we must to adjust.
Well, thank you for that. And as you continue to remain positive and continue to do the work that's required of your agency, I want to say thank you for allowing us to do the walkthrough of your facilities, and certainly the committee was impressed with the work that's being done by STEAM CMC.
2 minutes.
The Pajixet Health Center, and certainly as we continue to contemplate budget, we'll certainly consider, the valuable asset that you serve in this community. I wanted to ask you just spoke about the pandemic. Have you received any COVID funds from the GVI?
No, we haven't.
No funds at all from OMB, the governor's office?
No. No, the answer is no.
Okay. Very well. And in terms of revenues, do you collect any fees whatsoever outside of insurance, Medicaid or Medicaid, Medicare? Do you collect any revenues whatsoever?
The patient services is the primary and sole source of our operating monies outside of the reimbursements that we receive through the local appropriation, which accounts for the local match as well as support for uncompensated care.
What number have you pegged to your uncompensated care?
Miss
21 thus far.
Well, I know it is the second, the self-pay, which is the uncompensated care class, is the second largest payer class. So Ms. Dorset may be able to speak more directly to a specific number.
Ms. Dorset, real quickly.
I'm so sorry. We have, I would say, about half of our payments, patient income. The other half is actually supported through our grant, our federal grant, with the discount, our sliding fee scale discount. But we really have a very little that we receive from our patients. Because in most cases, these patients, most of our clients...
Time.
Okay.
Yeah, Mr. Chair, if I could just wrap up with 2 questions real quickly.
Go ahead, Senator Francis. Go ahead.
Issue. In respect to, Mr. Chair?
Yes.
Again, I was just having some difficulties in hearing
I'm sorry.
from the testifiers. In regards to the uncompensated care, we're trying to just peg, what that cost look like for STEAM CMC, what that uncompensated care amount is. Do you have any idea what that is?
Miss, I'm sorry, Senator, can we specifically get back to you with a specific number as of
yes,
today?
That's fine.
Yeah, I don't want to conjecture and then it's not accurate.
My final question is that I saw that there was some improvement with your presumptive eligibility program, and you moved from 80 to 123, which is a net increase of about 43. What do you attribute to that increase, and how can you maximize trying to ensure that you continue to grow that number? I'll appreciate a comment on that, Mr. Chair. Thank you for the time.
Through the chair, that is primarily attributed to that the program actually was able to stand up. There were some training delays initially, and we've been able to stand it up. And we also have been specifically identifying additional staff to support the presumptive eligibility. It's our intention that as we move forward, that we are able to bring more and more people through presumptive eligibility from now, actually, because we've moved around some staff and identified financial counselors and others to support that.
Thank you. Would you have your uncompensated number for last fiscal year? So you could at least have a ballpark as to...
I'll present both of those because I know we had done an analysis for Senator Frett, but I just don't have it in front of me.
Your CFO doesn't have it?
Ms. Dorset, would you have that readily available?
No, I don't have that readily available. We'll have to get back to you with that information.
Okay. I know you usually have a chart with that type of information. That's a figure that should be a part of the presentation because that's a part of the justification as to how much money this body would give to STEAM. You have to do a comparison as to what is the uncompensated care.
Yeah, we had done a full analysis.
Are you on target? I'm seeing that. Are you on target to get back to the numbers that you had before COVID?
We're on a current trajectory to get back there. We were able to, a large part of that delta had to do with the fact that our dental program couldn't operate at all for most of last year. So the dental program is back in full swing. We have additional providers on the medical side. Our behavioral health is ramping up. So we anticipate getting back to those numbers, if not by the end of this calendar year, into the beginning of next calendar year.
Okay. I'm seeing on your chart on page 16, your projected numbers for this year. Medical patients projected for this year is 13,571, which is an increase over last year, which was 10,000, but it's going to be a decrease over the 16,000 in 2019. So you think in 2022 we're going to get back the numbers that we had back in 2019?
Yeah, that's what our trajectory looks like. We've fully staffed up. We're recruiting another family practice provider to also support them.
Okay. Senator Sayo.
Thank you, Mr. Chair. What's your cost of your website?
I can hear you. I'm sorry.
The website.
STEEMCC.org.
Tell me what do you pay a vendor to maintain the website?
No, that's all in-house.
As long as it's your header. It's in-house.
Excuse me?
No, that's a good point that it's in-house because
that's all in-house.
Across the government, we're paying exorbitant rates for maintenance of websites when there's a BIT that exists. And then say electronic records, that professional service, your electronic records would be, explain to me, so I don't have to follow up. Who's that? Who could answer that?
The name of the system or the?
Yeah, what's the name of your system?
We have a system called Greenway Health Intergy.
Okay, so does that system include the phones that translate?
The system integrates with the phones that translate, but it doesn't. The translation service.
So who maintains the phones that translate?
That's maintained through the company that we have this service with.
What's that company's name? I'm looking at your professional services contracts. That's why I'm trying to find that.
Oh.
That would be Language Link.
And what's the cost of that contract?
Off the top of my head, I don't know right now.
Is it a yearly contract?
It is a yearly contract.
Okay, I need, before it's done, can I have the amount of that contract? Salary raises, I don't know if it was asked before, where are we on it? Last year you said increases for salary. We're here again this year. Tell me the status of salary raises.
Well, I would be proud to report that we are finalizing our plan. We reported to staff of that yesterday that we are finalizing our plan. We are meeting with our Human Resources Committee of the board to get final approval on the plan next week, once we schedule.
Save a
And we're
timeline.
looking at August to have
August?
them inputted.
I'm gonna call you August 31st, or whatever the last day in August is, okay?
August 32nd or 31st?
Or September 1st, either or. Okay, let's talk about this GRS situation.
Mm-hmm.
When you took the helm, I know that you had the lawsuit to remove the employees from the government employees retirement system, correct?
Well,
But you claim, well, your argument was that you are an autonomous agency.
No, we're a
that
private nonprofit.
You're private nonprofit. Lose the mic. You make okay. That you're a private nonprofit, and that it was illegal for the employees to pay into the retirement system. Correct? That was the argument made.
Well,
correct me.
We can speak off the record, but since we have litigation pending, and some of those arguments are substance to the
2 minutes.
litigation.
So you still have litigation pending?
Yes, we do.
So did you, okay, so what is the status of those employees that were members of the retirement system and tenured? And what is their status? Tell me that process. It becomes a budget question because it involves funding. So those employees that were a member of the system and they were tenured, and in the case, because I think you want a part of that case or whatever, what's the status of those employees?
That's what's central to the current litigation. So I could speak with you off record if that's okay, but
Okay,
I've been
so
advised not to discuss any aspect of
where's
that.
your legal counsel?
Our legal counsel is Miss Charmaine Brathwaite.
Where's Ms. Bratwood?
Ms. Brathwaite, we have outside counsel handling that, so she wouldn't be here.
So, okay, so the question would be, the employees now, what is their pension plan, retirement plan, what are they on?
We have established since 2017 a 403B program, which is similar to a 401k, but it's for nonprofits, and that is the pension plan that we have.
Okay, so you may be in litigation, but the employees are no longer part of GRS, clearly, that were tenured. Were they made whole? Yes or no?
I hesitate to answer because that's central. That whole piece is central to litigation.
Okay.
I don't mind speaking off the record, but I wouldn't do so here.
Okay, do you have a timeline on some closure to that whole GRS situation?
It's currently before the court, and the court should be acting. Hopefully this year will be closed out.
Because
Hopefully this calendar year.
if I were paying into a system for so long,
Mhm.
and this is my pension, and then, Steam CC decides that, which is your right
Time.
to, that you are nonprofit, private, and then you should not be paying to the system. Again, that's the argument. I'm not debating the integrity of the argument. And then but the employees are the ones that remain in the crosswinds of them being members of the system for so long, and then we rule, you're not a member of the system anymore. We go to this 403B. What is the status of the money that they put into the system? Were they made whole? Did they receive the employer contributions? Like all of that, and I know you have a case to close out, but I don't want people to be in limbo for so long.
Oh, well, let me.
We can talk offline.
Yeah, we can talk, but let me just state this. It's not and never has been the intention of the board or the executive team to displace any staff. What we're doing, and
You
by
realize the unintended consequences.
but what we're doing, and the reason why we are moving litigation is to ensure that our employees are properly made whole. So we could speak offline, but it's not, I don't want there to be the perception that the health center is moving in a way to displace staff. We have had...
My argument, I'm not,
okay.
my worry is not at this, Mr. Chair, with your indulgence, is not trying to paint an image that you're
Okay.
trying to I think I speak plain English. I'm being direct in my questions.
Mhm.
If I wanted to say that you were doing that, I would have said that, a long time ago. I just wanted to make sure that those employees would be made whole, and if it was the priority of STEAM CC to move in that direction.
Well, that is our full intention, but I'll speak to you more offline. I wouldn't put that on the record since we have litigation pending.
Okay. Thank you, Mr. Chair.
Okay, thank you so much, Senator Sayo. Senator DeGraff.
Thank you, Mr. Chair. Good afternoon, colleagues. Good afternoon, testifiers. I understand the litigation, but again, employees are number one for me always. Since the litigation, is there any money still going toward GRS until it has been settled?
We have, a portion of our action have already been settled. And that action is that the GRS has already settled that as a private nonprofit, we're not a member of GRS. That has already been settled.
Okay.
Okay. The only employee, which is one employee, who was transferred from the government over is the one that we continue to make GRS payments, because that's the only employee that GRS recognizes as having carryover membership. The other is that the other aspect is the fact that GRS holds the funds, and we have to go through a process to ensure that we're able to make our employees whole. So I'm not going to go into the details of the litigation,
No, right.
but that's what and it's not a high number of employees.
Okay.
I want to kind of settle that. It's not contributions that the employees themselves have made. I believe that those have already been settled out by GRS. It's another set of funds that are being held by GRS, and we believe that we're going through that process to get those properly released.
In the prior testimony, I heard 2% per annum for wage increases?
No, 2% was really an inflationary number we use for budgeting purposes, but not necessarily for wage increases.
Okay, so when last have your employees received a wage increase?
The last structured wage was probably 2017, 2016.
And
2016, it wasn't 2017.
2016?
Yeah.
So when will they be due for the next wage increase?
Well, we are finalizing a plan now. We finalized a plan. We're meeting with our Human Resource Committee of our board, and it's our intention, if approved, to look at implementation in August.
Okay,
next month.
So it's not a negotiation. It's just basically we are telling you, we are taking you to this.
Yeah, we're not a unionized shop. Yes, okay. But the fact is that we want to ensure that we are fair, that the employees are recognized for the hard work that they have been doing. In the interim, even though we weren't able to sustain increases, we've been able to do certain things to accommodate that. But what we have done is we've done some very generous bonuses in 2019. We've done a moderate bonus last year, and we're hoping now, this year, once approved, to kind of bring the level of compensation more in line with where the market is right now.
Okay, great, yeah. Great news to hear. Now, you've done some expansions. Are all your expansions completed?
The short answer is yes.
Okay.
COVID has brought us into a scenario where you can't operate without space.
Right.
And one of the areas which is really a marquee issue is the fact that there's such an overwhelming need for behavioral health services that the health center made a priority investment in expanding behavioral health, using a lot of our federal funds to accommodate that through COVID last year. That we have completed our behavioral health wing. We've been able to bring on additional support services and also some state-of-the-art equipment. If you don't mind, I have here with me the director of behavioral health.
Was that put out in your testimony?
Yes, it was.
Okay, well, elaborate on it again for me. The gentleman can speak. Yeah.
Okay, I will. If you don't mind,
no, that's fine. That's a part of your expansion that I asked, so that'd be fine.
Yeah.
Good afternoon.
Good afternoon,
I'm Dr. Zen Maservi, and I'm the Director of Behavioral Health and the psychiatrist that's overseeing the program. We have some of the things that we have initiated is actually we have begun to service a significant increase of patients throughout the St. Thomas, St. John area. Having been both previously over Schneider's behavioral health and been involved in many of the different processes, I saw the importance of what we needed to do more out in the community.
Time.
You could just wrap up and then have one last question.
With,
If you may. Yeah.
Yes, go ahead.
Okay. You could just wrap up and then have one last.
With that, we have brought in many different services, including state-of-the-art technology currently with transcranial magnetic stimulation, which is we're the only place in the whole Caribbean that has that. So many different options and services to patients and to provide it.
That's good news. Thank you. And finally, I was wondering, the facility out on the Rima Highway that's being built on the left-hand side, is that Steam CC property? If anyone knows?
It is the Hartman property that we've leased.
Okay, and your build out for that is in this budget?
I'm not sure. I cannot tell you,
You
that
can't tell-
right off
okay.
the top
You
of my
don't know?
head, but
No?
when Mr. Smith does return, he would
Okay.
more than likely be able to speak more to that.
Yeah, you know the facility on the highway going, so that'd be at your final when he comes back. Thank you.
Okay,
for your time.
we'll have that question answered, but we're going to take a 2-minute recess.
Thank you.
Somebody sounds a recess for 2 minutes. The Committee of Finance is back on the record. Senator DeGraff, your question in reference to the property. You may proceed.
Yes, thank you, Mr. Chair. Director, I was asking about the facility going out on the highway on the left-hand side. I was told that it is yours, and I just wanted to know some updates on it in regard to your funding sources and, you know, what has been spent and what is left to be spent on it.
Okay. I don't know if it's through the chair or whichever. The property is actually immediately across from where the curriculum center currently is. I guess where they relocated to with the Edith Williams. But
Edith Williams. Okay.
Yeah, they're directly across from that. I think the Leonardo Trotman Road entrance would be where the boundary is. Okay, so there's 2 acres of commercially zoned land. The location, there's a structure going up on the, I guess, immediate east, northeast of our property. It's not CC construction. That's another. The funding, we just entered our architectural engineering contract with the firm, and we put it out to bid last year in November, and we were able to finalize that and finalize the contract. We actually have architectural kickoff next week, and we already have term sheets through a private funding source for the construction. They're finalizing the underwriting now. As a matter of fact, Mr. Baines and my staff and I were working on that just before coming here. And we're anticipating that it will be federally secured funds through a private entity that we will use for the construction. The architectural and engineering work is through the Department of Interior funds that we were able to have reprogrammed through the CIP program.
Okay, thank you for that. No COVID funds?
No COVID funds.
Okay, thank you for that.
Excellent in creative financing to get this project done. How much COVID funds have you received?
We received 2 tranches of PPP, and which in the amount of just under $1 million is 900 and some $1,000 per tranche, both for PPP 1 and PPP 2 were the same amounts. Those are not considered grants yet until they're written off, but they're still carried as loan debt.
And as a nonprofit, you qualified for PPP?
Yes. Yes.
That's good.
But so we're in the process of the loan forgiveness for both of those now, but we're anticipating that they should be. But as of today, they're still on the books as a loan. We received approximately $662,000, give or take, for COVID care funds. We use those fundings to support our behavioral health expansion, to support our expansion in outreach and hypertension, and we wrote that grant, we justified that grant for both expanding, reconnecting patients with service, because was a very big need, but also identifying where some of the emerging gaps in need would be because of COVID, and that's where we use for behavioral health and outreach and some other activities. We received about $200,000, $202,000, what we call expanded capacity and testing, and we use those funds to accommodate some of our minor build-out activities. That's what we use to accommodate both the central waiting space where we met,
yes,
as well as the intake space and some of the areas in behavioral health. We received $58,000, just a little more than $58,000, which was used to support testing, PPEs, et cetera, for our staff and for others. We recently received, recent being April of this year, we received notice of $1.8 million over 2 years out of the American Rescue Plan funds. We have, and though it's COVID related, it also had a little more expanded usability, and we're using those funds to augment additional staff, to bring capacity. So those would include some of the new hires which we just brought on, which were quite a few. We brought on 10 employees over the last 3 weeks, and that would accommodate some of that so that we can get back to seeing patients and also get back to the ability to enhance our compliance. So those were the funds that we received.
Well, congratulations. I'm glad that you received those. That's probably a little more than 4.5 million. So that's very good to supplement the work that you're doing. Senator Carrion, you recognize.
Good afternoon once again to all my colleagues and everyone who's viewing and listening. And good afternoon, Director Smith. How are you, sir?
I'm well, and good afternoon to you.
Good, good. I know you're usually on point. Today it seems like, you're missing some important information that should be part of your justification of your budget this afternoon. Doesn't sound something usual, but we're hoping that you would submit the information that some of my colleagues have requested that I believe is necessary for us to be able to fully evaluate and make determinations. I have a few questions, not much. And just so you could kind of simplify for me, and some of this is within your testimony, but I just want you to clarify. What would you say it's, in your case, one of your main budgetary challenges?
That's like a compound fracture. That's a question that has so many different stress areas that it's hard to say just one. As part of this process, because we're here because of the public fund side of it, the local public fund side of it. So as part of this process, our challenge has always been underfunding. Underfunding for the obligations of the public sector to the indigent and others who would make up what we consider to be uncompensated care. Now, on the public side, now one may ask why I say that as a nonprofit, and because we're a component of the public health system. I say that because the public side is offering very little services. Okay, the services to the community from the clinical side is very limited. In some cases, it's not at all. And as a result, a federally qualified health center, in this case St. Thomas Eastern Medical, is now carrying all of this public risk, and there's no priority about funding it. So that is, as part of this process, I would say that is the #1 challenge, and I know there's many constraints. I know we're constrained by a number of things, but at the end of the day, it is a public obligation, and if we are carrying, I would say, 85–90% of that risk, it should be well stated, well intentioned that we need to, as Senator Marvin Blyden said, reel and come again because it's not working.
2 minutes.
Got you. And given that fact that you mentioned, if I understand clearly, you don't have on hand what's the amount for underfunded or uncompensated care. You don't have those numbers with you.
We present that every year. We present an analysis. And this isn't a new topic. Yeah, so we could provide them, but I don't want there to be a cloud that because we came here with the assumption that the request was approved. Okay, that we did not have to justify what we've been justifying, that's me, for the last 12 years. So I could provide them. We didn't believe that we'd have to so much.
I hear you,
okay.
And of course, I had an opportunity to walk through your facility, and I was amazed to see everything that you all do, and how you have expanded the services that you provide to the community, which I must commend you for that. But as you know, we have a responsibility, oversight, and to ensure, and this is part of the process. Part of the process is you provide the information, the justification for the services, and we ask questions that have to do with regards to the budget, because that's our responsibility. So those numbers are very important for us to have an idea of, what that is. With regards to just for general knowledge, what are you projected in operating expenses for FY22?
I think if you turn to it's in the packet. Let me try and reference the exact page. If you reference page 14 of the document, and my packet is different numbering sequence because it's printed differently. Yeah, it's on page 14 of 33, and it's outlined there.
Yeah, I'm sorry. I really was interested in to find out your current operating expenses. What you projected for FY21.
Ms. Dorset, can you speak to our current year operating expense projections?
And what are your actuals?
Hold the Senator time, Ms. Dorset. Okay, Sam is done.
About that. That information was sent in with our first, with our request. That was sent in with our financial reports to the Senate. So I would have to now pull that information up, and then I would be able to look at it and give you that information.
I didn't see it in the post-audit report.
Okay, well, it was sent to the post-audit.
That's why I was sent to have an idea where you are, we operating expenses, to be able to make the comparison to what you're projected for this year. So you don't have any of that information on hand?
No, I have it in my computer, but I'm still trying to stay on this Microsoft Office and go into my computer and look for different things.
Okay.
Time.
Director, or maybe your CFO, with regards to the revenues that you're generating, what do you attribute the projected amount for FY22?
It's in the document. I'll point you to the page 15 of the report has our projected FY22 revenue projections.
Oh, here it is.
It has the projected expenditures and projected program income.
And are based on, that's what I'm saying, what do you attribute it to?
Excuse me? I didn't hear you, sir.
What are you attributing those projections to?
The projections are always based on patient encounters. So when you look at how the patient encounters are projected to aggregate up, based on the level of services that we'll be providing, numbers of providers, et cetera, that speaks directly to the program income.
Time.
All right, I have one last question. It's not really budget related, but
Go ahead, Senator Carrion.
Your behavioral health program that you have expanded. Are you planning to implement? That's already implemented, or that's something that you're working on to implement?
Our behavioral health program has been up since 2017, and we are made a strategic decision to expand it based on the needs of the community. So it's already up, but it's expanding, and we are anticipating doing a number of state-of-the-art things with that program.
All right, thank you, Mr. Chair, for your time.
Thank you, Senator Carrion. So you have Ms. Dorset as interim. What happened in terms of?
Ms. Dorset retired in 2017. Not 2017, I'm sorry, 2019. And we were anticipating having our site review and audit, so she has graciously agreed to stay on with us while we recruit a new CFO and go through the audits and the site review. COVID came and dates were extended, and so she has graciously, and I have to publicly say thank you to her, agreed to stay on. Now we have selected Mr. Eric Baines, who is on the Zoom, who will be our incoming CFO of August 1st.
Okay.
Yeah.
Yeah, it's important to have the information, I mean, the uncompensated care, the actuals, et cetera. There's one thing, it's a submission, but the next thing is when you come and we ask basic questions that we believe should be answered, we should be able to get that information as to, what are the actuals, that give us a good idea as to the direction we need to move. We have departments that are coming and requesting $5 million increase in personnel, and when we look at the projections, they're going to fall $2 million less than what we projected the year before. So we need to know so that, and I think more so we need to know because OMB has now indicated that they made a mistake. You have projected what your amount, what your suggestion is. So we now need to make a decision as to where do we go? Do we go with the higher? Do we go in the middle? Do we go at the lower end? But we can't do that unless we have the requisite information. Senator James, you recognize.
Good afternoon to the people of the U.S. Virgin Islands. Thank you, testifiers, and thank you for all that you do at the St. Thomas East End Medical Center Corporation. I see here in your closing statements you made mention of expansion to the behavioral health program that you provide. Can you speak to me which funding source will be used or which grants will be used for the further expansion of this behavioral health program?
Yeah, certainly, sir. We used federal COVID funds for the construction and the procurement and acquisition of the state-of-the-art equipment and diagnostics. We use COVID funds to recruit a therapist, and the other aspects will be generated based on our program income, the services that we provide, and the reimbursements.
Thank you. And it's very important that we focus on the expansion of behavioral health programs in the territory, and I think it's the same for the Frederiksted Clinic and Cerebral Initiative, so I'm glad that you're doing it as well in the St. Thomas, St. John district. But we continue to hear the words throughout government and the private sector, workforce development and capacity building. And I once again, in your closing statements, you made mention that you're trying to work on workforce development as far as a continued emphasis of the St. Thomas East End Medical Center. So as far as your conversations with Department of Labor or anybody when it comes to the 2040 Vision Initiative, have you been included in those discussions? Do you sit at the table to make sure in the next 20, 40 years from now, we solve our workforce development issues?
Give me 1 minute, Director. Senator James, I'm going to come right back to you, okay? I'm going to take a 2-minute recess. The Committee of Finance is back on the record. Senator James, you may proceed. Go ahead, Senator James.
You heard the question?
No, we didn't hear anything.
How much time do I have on the clock so I can have an understanding of where I'm at?
3 minutes.
I was in 2 minutes, only asked one question. Thank you, anyway, thank you.
Let's go ahead. We're gonna accommodate you. Don't worry.
Here in your testimony that you made mention that you do not receive local government funding specifically for the healthcare center for serving our HIV population. Did you receive funding in the past?
We don't receive any specific appropriation, but we are in partnership with the communicable disease of the Department of Health to do treatment for the HIV population. There is some CDC funds that they've made available, but there's no local funds.
In a total of how much?
I mean, it's a moderate amount. The first tranche was $45,000, and those individuals who are patients of ours, they are reimbursed based on we're reimbursed based on regular services that are provided, but there's no special funds at the moment.
Which leads to my next question: do you serve a high amount of people, a large amount of people, when it comes to individuals who are living with HIV?
Yes, we do. Yes, we do.
So if that's the case, we need to pay attention to it. Not saying that we're going to promise you anything, but when you put things in your budget, or in your testimony, we don't take those things lightly. When you say local government has been specifically designated. So if you had a magic number, if you had things your way, how much would you like to receive to be able to assist with that high population that seems to be growing when it comes to HIV patients?
Well, everything, we normally, with this process, always project what our costs would be. So our full appropriation request would always be a magic number to start with. The other is, the other would be about $100,000 thereabout to support those with HIV who are self-pay. Those who don't fall into any other program.
Okay, because remember, it's a budget hearing, and we want to make sure that we are able to tend to those individuals in the community. We don't want to leave them unnoticed, because we don't want individuals to continue to spread such disease or viruses. And I think I was told, or I saw in some testimony recently, we had somebody before us, and I think it was the Department of Health. Department of Health came out to defend the budget the other day, and they made mention that they are seeing some increase in technology when it comes to assisting individuals living with HIV, and they tend to have more programs and services assisting them. So do you have that communication with the Department of Health to tap into some of their resources?
Well, that's what we do coordinate and partner with communicable disease component of the Department of Health around HIV support. We never turn away patients who come to our health center for service. So whether the funding is always there or not, we always ensure that patients are treated.
Thank you. And I see here that you have a cost of $50,000 to be budgeted for recruitment. And you said that the recruitment will cover classified and journal advertisement and candidates interview costs and page telephone listings. As far as your recruitment efforts, what are your focus areas as far as getting individuals recruited? Or are you talking about recruitment for customers, gaining customers?
No, through the chair, these recruitments speak specifically to the recruitment of providers and other high demand professionals to come to the health center as employees or providers. So it's not the recruitment of, it's not the marketing for new patients. This is specifically geared at recruiting providers, and the high demand area we have right now is psychologists, internal medicine, OBGYN, and family medicine. Those are I would say, would be the top areas of provider recruitment need.
Thank you. I think my time was called by now. I just want to end by saying thank you for coming down before us and defending your budget. And in closing, I just want to say, as we speak about this 2040 vision, I know the 2040 vision speaks to health sciences, telemedicine, medical simulation, specialty care, and education, in which the chair has stressed on earlier when it comes to the Snyder Regional Medical Center. And if we're going to be serious about healthcare in the territory as far as a long-term vision in this 2040 plan, we need to make sure that we have the key stakeholders involved in the discussion to make sure that in the next 20 to 40 years, when I become an older guy, that we can see improvement in the territory. Thank you, Mr. Chair, for the time.
Well, thank you, Senator James. In terms of going back to the question you asked for your HIV program, you don't receive any of the Randy White federal grant?
No, we're not. That grant goes more directly to the Department of Health, but they do work closely.
Okay.
They do work closely with us.
I'm trying to remember the budget for East End. I think that's a substance. They get some good money from that particular grant source.
You mean St. Croix?
Yes.
Yeah, you said East End.
I'm sorry. They were quite a bit of money for that grant.
Yeah, they were able to apply directly to CDC for that, and we're in the process of
I think you need to take a close look, because it is applicable to federally qualified health center, and they get a couple $100,000 for the administration of that particular grant, that you can use that to supplement the work that you're doing with our HIV patients.
Yes.
Senator Potter?
Thank you very much, Mr. Chair. Good afternoon.
Good afternoon.
Mr. Smith and your executive team, and Ms. Bryn, the chair of the board. Welcome. I want to start really by thanking you very much for what you do. I know the work that you do is really badly needed in this community, and you do you're quietly doing a good job there at East End Medical Center. I was pleased to have had the opportunity to tour the center to see what goes on behind those walls, and you guys are doing an excellent job. First of all, we have a mental health crisis in the Virgin Islands. I think there's no doubt. The commissioner or the director of corrections was here some time ago, and she was talking about the fact that they function as a de facto mental health clinic at the Bureau of Corrections. So I am very pleased to see the aggressive moves that you're making with regards to the standalone behavioral health unit. How has that been going? Do we have a strategic plan in place to get the word out, to get Virgin Islanders to utilize these services? Next part of the question is, does the FY 2022 budget adequately meet the needs with respect particularly to the expansion of your behavioral health unit?
Okay, I'm going to answer the last part of your question first, and then I'm going to turn it over to Dr. Meservey to speak more specifically about the behavioral health and the expansion. The budget, as announced when we came, does not. We submit a budget call every year, which specifically speaks to the needs of the health center, and we're very meticulous in supporting that. So we do. So the amount that we originally requested, the amount that was included in the budget book, would actually be more adequate to meet the needs of both the behavioral health program, but all of our other programs. We will have to look at other things, but rest assured, we're not going to diminish our services to patients. That's never an option, and we continue to move along the track of expanding and increasing our services. So, Dr. Meservey, if you could speak to the program itself.
Good afternoon, everyone. I wanted to address the fact that actually we've already started significant progress in regards to psychiatry and behavioral health. We currently have psychiatry, psychology, and social work ongoing. We provide therapy, psychological, and psychometric testing.
2 minutes.
We provide medications, including long-acting medications. We are currently 95 to 100% compliance with those that are on our long-acting medications. We have brought down this transcranial magnetic stimulation, which is going to be another type of therapy in order to treat depression, anxiety, and even migraines that without medication. We are providing case management. We've started a high-risk patient track, and we have 20 patients that are enrolled in this, and these are patients that normally are lost out in the wilderness, so to speak, in getting services. We have laboratory services. Continuity of care. I have been out at the homeless clinic since pretty much since I landed here in St. Thomas, and consistently have had many homeless people. Currently, I'm proud to say that the majority of the patients that are homeless clinics, we have brought into our clinic and started to provide services for them. We currently have 14 patients that are from the homeless clinic. We also, I continue to service the homeless clinic regardless, but the numbers there have dwindled because we are providing services for the community. In addition to that is we are a first response to the emergency room over at Schneider Regional Medical Center, trying to get people that are going into the emergency room to get their medications refilled that are not there, and so they can refer them to us. We can get them in. We try and get them in within a week time, and also the referral source from the behavioral health unit. We have been working towards branching to support or connect with other agencies, including we have reached out. These are all connections and things that we have already made, including NAMI, the National Alliance for Mental Illness, Voc Rehab, the Homeless Clinic, St. Thomas Healthcare Management, or CView, to follow their kids before their discharge and afterwards, Co-Victims United, Lutheran Charities, Catholic Charities, and along with Elder Schulderbrandt and Community Mental Health Clinic or supports there.
If I may just briefly, Mr. Chair.
Yeah, go ahead, because you had a long answer, so go ahead.
Okay. What impact, and I'm just trying to understand, I know we're going to have a process of deliberating and making some tough decisions, prioritizing limited funding. What impact would a reduction in funding, from your original submission, what impact will that have on you realizing your vision, particularly for the behavioral health unit, which I think is critical in this community? What impact will that have?
Well, I mean, it will potentially slow our expansion, and if you look at the status of behavioral health holistically, comprehensively, I should say, we are providing a high volume of that service in St. Thomas, and with the storms, and with COVID, the come through of that, the impact we have on both children, the elderly. We're talking about there's a real high number of people in this community that are in immediate need of services, and when the budget curtailment will impact the speed to which we could get services out to the community, and the speed to which we could get patients to us to support that.
Okay. A final question is regarding your expansion, and I know that it is an ideal location that you have up there at the mall. It's on the bus route, it's on the bus lane, easily accessible as far as transportation is concerned. Will that new site bring challenges as far as accessibility to the facilities
Well,
when compared to what we have right now?
The first order of action that I did once we were in the architectural procurement stage was to meet with the Deputy Chief of Staff of the Governor's Office for the express purpose of bringing the various entities together that would be intricate to the permitting, but also the planning. We are anticipating again having all of the accessibility items proximate to the new site, including bus stops, including traffic lights if available. You know, we know that funding is there. I know that there. So we through our architects and our on-staff project manager will be coordinating that to ensure that it is just about seamless. But one of the key aspects, though, is that space. The space and the cost for space. Our landlord is gracious, and I will never not say that. We have a very good landlord, but there comes a point where your demand for space and the cost you're paying only makes feasible executive sense to look at controlling those costs and be able to control your space.
Thank you very much, Edie Smith and your team. I won't abuse my time, Mr. Chair. Thank you very much for your generosity.
Thank you, Senator Potter. I heard your discussion in reference to the work you're doing with the homeless population, etc. What type of partnership agreement you have with Department of Health, Department of Human Services that is charged with homelessness? I know that we have received COVID funds that specifically can be utilized for the treatment of the homeless population. What is the partnership agreement that you have with these entities?
I will speak from this level. I am, as Edie, I'm on the homeless task force. We haven't gotten to the point where we talked about distribution of funds yet, but I am on that task force, and they are that working group task force, and they are planning. It's primarily a planning group.
Okay.
We work more directly with the VOC Rehab, vocational rehabilitation program of the department, and I know that they are in more direct communication with the operational side of the health center.
Now even the VOC Rehab is federally funded.
Mm-hmm.
How are they? All of these pockets have federal monies. They're coming before us. We've seen the federal grants and monies are not expended. We have COVID monies for specific purposes. The monies are not expended. You're filling a gap in some of these areas. So my whole thing is that it's not all the general funding source that need to be utilized. There are federal monies there that are not being utilized. You spoke about behavioral health. We just purchased a behavioral health plan. Mm-hmm. What is going to be that partnership if you're already working with the homeless that has mental issues? What is going to be that partnership agreement in terms of making sure that our van is utilized every day instead of being parked up? What is a partnership agreement in human services, utilizing some of the homeless COVID fund to an entity that is actually treating the homeless? I think we need to elevate the discussion that we have, and you're dealing with CVU. CVU falls under Department of Education. We recommend students to go there. Those students have a disability. We receive millions of dollars for students with disabilities through the Department of Education, to the point where we have now entered into partnership agreement with certain entities for autistic children, et cetera, that are getting monies from the Department of Education for the treatment of those individuals. So are you being compensated in all of those buckets that you're providing service? If you're providing service for our students at CVU, they go through an IEP, an individual educational plan, et cetera, and specific monies are dedicated to make sure that those children receive service.
The short answer is that we, when I say we, the collective we, need to actually do a much better job in coordinating and leveraging these funds. Okay. And I'm hoping that this discussion here could be a catalyst to make that happen. I know Dr. Muservi wanted to want to elaborate on something?
I just wanted to say that we do not get a whole lot of funding, but however, we have reached out to make sure that some of these patients do get follow-up services. So what we have done with Seaview specifically is we have started to contract with them to get them to bring their patients to come see me the half a year before they're going to discharge them, so that when that patient leaves there, has no place to go, they've already connected with me, and we've come in, and so we can continue to provide them medication and other services. And those are things that we do not get additional funding for, other than whether they're on Medicaid.
And that's a transitional service that you're providing for the DOE. We need to look. I just encourage, let's look at those buckets of monies that presently exist, our federal funds. I think Voc Rehab sent back quite a bit of federal funds, and they have been sending back quite a bit of federal funds for the last couple of years, because they're just not expending all the monies. Special Ed has a tremendous amount of federal funds, and I know when we had the meeting with disaster recovery, and I'm trying to find the exact funding source, but I did see COVID-19 funds for homelessness. So, and you're treating the homeless. So I know that we can tie in. I think as a government, we need to be creative in terms of the language that we're utilizing for all of these buckets of money that exist. The Ryan White, I said Ryan Lee first, it was wrong. I think it's Ryan White.
It's Ryan.
It's Ryan, right?
Yeah, right.
Yeah. So a lot of money is in that particular tranche of federal funds available. You get along well with Fredericksburg Health Center. It's just to have a discussion. We should replicate their application. We shouldn't even be trying to create a whole new application. Just ask them for some of the information, and let's go from there. And colleagues, if there's no more questions, I'm going to allow Mr. Smith to put a closing statement on the record.
I just again would like to thank you and the committee and the other senators who may have participated for allowing us an opportunity to speak to our funding needs for the upcoming fiscal year. We appreciate, and I always welcome your inquiry. It's part of the process. It's robust inquiry is always necessary to ensure that we are all transparent and that we are all moving in a direction that best serves the people. I want to publicly thank our staff who have been the best. I have to say we have the best staff. Bar none, we have the best staff. All throughout this COVID pandemic, regardless of whatever their personal situations may be, they came to work, they showed up, they continue to serve our patients, and you can't want a better commitment of people than that. I'd like to publicly say thank you to Ms. Dorsett for accommodating us even through her indication of retirement, and to Ms. Bryn and the other members of our board of directors. We know that, at least I know, that there's some challenging decisions to be made when markup time comes, but I yield to whatever accommodation that can be made for an increase in this, the revised budget number, because let's face it, we're in a pandemic. There is very few other public spaces that are serving our community, and though we're in a pandemic, it doesn't stop hypertension and diabetes. It doesn't stop all the other ailments that impact an aging community that we live in, and we're serving that pocket. So any accommodation you can give will be greatly appreciated. And I'd just like to say again, thank you, and all the best. Thank you.
Thank you so much for your testimony. Thank you to the members of the Eastern staff for being there all throughout COVID and continuing to serve individuals who are underserved by the government of the Virgin Islands. The Committee of Finance will take a 5-minute recess.
The Committee on Finance is back on the record. Madam Clerk, can you read the next item in this block?
Office of Collective Bargaining. Invited testifiers, Joss N. Springett, Esquire, Chief Negotiator.
Thank you, Madam Clerk. Attorney Springett, no one's on virtual for you, right?
Yes, Senator.
You do?
Just one.
Okay. Testing?
Hi, good day. Oh, I'm sorry.
No, go ahead, go ahead. State your name and your title.
Good day, I'm Joycelyn Durant. I am the Director of Business and Administration for the Office of the Governor.
Thank you, Ms. Durant. And then please state your name on the record and title.
Good afternoon, Joss Springett, Chief Negotiator, Office of Collective Bargaining.
Thank you.
Good afternoon, Senator John Touloud, on behalf of the Office of Collective Bargaining, Assistant Attorney General, Labor.
Thank you.
Good afternoon, Senator Suleima Chapman, Assistant Attorney General, Labor, assigned to the Office of Collective Bargaining.
Thank you, attorneys. Attorney Springett, you may proceed with your testimony at this time.
Okay. Good afternoon, Senator and Vice Chairperson Janelle Soro, Committee on Finance, other members of the Committee on Finance, non-committee members in attendance, the people of the Virgin Islands. My name is Joss Springett, and I'm the Chief Negotiator at the Office of Collective Bargaining. I appear before you today to recommend and support our proposed budget for the fiscal year 2022 in the amount of $1,199,480. Appearing virtually with me today is Joycelyn Durant, Director of Business and Administration at the Office of the Governor. Present with me is Zulema Chapman, Assistant Attorney General, Labor, and Jean Touloud, Assistant Attorney General, Labor. I will begin my testimony the way I usually end, by thanking my staff. Your unwavering support and commitment is second to none. I am a better leader and public servant because of you. Thank you. Overview and composition of the Office of Collective Bargaining. Through Act 4440, the Office of Collective Bargaining was established in 1980 within the Office of the Governor and under the Division of Personnel for budgetary purposes only. The office's mandate can be found in Title 24, Chapter 14, Section 377. Through Act 8365, the office is no longer under the Division of Personnel. OCB is supervised by me, the Chief Negotiator, and its statutory responsibilities are as follows. 1, exclusively represents the executive branch of government and its departments and divisions, and negotiates on its behalf in all collective bargaining proceedings. 2, assists the governor in formulating labor policies for collective bargaining and plan strategies for such bargaining. 3, coordinates the government's position in all mediation and arbitration cases and labor disputes. 4, conducts systemic studies of the collective bargaining agreements for the purpose of contract negotiations. And 5, prepares and submits an annual report and such other reports as may be requested to the governor and the legislature on the effects of this chapter on the annual budget and personnel matters. We have an office in each district that is currently staffed by a team of 4 employees and 2 Assistant Attorneys General, Labor. The attorneys are assigned to the office by the Department of Justice. OCB's current employees hold classified non-union positions, and the Assistant Attorneys General are exempt employees. The team consists of professionals with a wealth of experience in administrative functions, customer service, labor relations, human resources, arbitration, general legal practice, labor and employment law. Our organizational chart is attached. Proposed fiscal year 2022 expenditures. Personnel services. Our proposed budget for personnel services is $677,546 which represents 56.5% of the overall budget. Fringe benefits are projected at $316,934, which represents 26.4% of the overall budget. Equipment and supplies. Our proposed budget for equipment and supplies is $31,000 or 2.6% of the overall budget. This amount covers our paper, printer, and cleaning supplies and other items necessary for the day-to-day operations. Utilities. Utilities costs for fiscal year 2021-2022 are projected to be $10,000 or 0.8% of the overall budget. We do not pay supplies or utilities in the St. Thomas office, so this amount only covers the utilities on St. Croix. Other services. Our proposed budget for other services is $164,000 or 13.7% of our overall budget. These funds cover operating expenses including rent, service agreements, IT, communications, and training. Next is a full overview of the 2022 budget based on the different accounts and percentages. Operations. We continue to adjust to the demands of our office, hire more personnel, use technology, and consider various options to streamline operations and allow us to work efficiently regardless of our location or current conditions. My team and I continue to increase our knowledge and learn new trends in relevant fields by attending in-person and virtual trainings and staying abreast of recent case law and guidance by authorities such as the Equal Employment Opportunity Commission, Society of Human Resources Management, SHRM, and the U.S. Department of Labor. In regard to hiring more personnel, the Department of Justice assigned a second Assistant Attorney General, AAG, to our office in May. OCB also hired a paralegal for the St. Thomas office who will start next month. These two additions to our team will greatly help with our large caseload and other legal matters. Our caseload has hovered around 260 over the last year. We also hired a financial management officer who will start next month. This person will handle the fiscal and human resources duties as well as the financial. For a financial specialist so that we can accomplish these goals while completing the day-to-day responsibilities such as payroll, monthly expenses, and addressing HR matters. Many thanks to Director Joycelyn Durant and her staff in the Business and Administration Division of the Office of the Governor for their assistance with these duties. Labor relations. OCB's mission is to fulfill our legal mandate to fairly engage in the collective bargaining process and enhance the relationship between labor and management. Our goals are to continue training management in labor relations, reduce labor disputes, and improve labor relations between management and labor. OCB receives calls on an almost daily basis from agencies seeking guidance on legal issues, organizational plans, for OCB's intervention in various collective bargaining matters. These discussions provide us with insight into the agency's operations, their challenges, and how OCB can better serve the government. Our open dialogue with the unions continues and serve as an important factor in labor relations.
committee is back on the record. Quickly, Attorney Springett, on page 2 of 6, post audit. Your personal services, of course, you indicated you are adding a paralegal and what else? What other position?
One moment, please. Said on page 2 of the post audit report.
Yeah, on your personal services, an increase of 281,300.
That's about it. Okay, when it comes to training, you mentioned training several times. I spoke to your financial professionals, and you also spoke to, no, I'm sorry. You spoke to your management in labor relations, and your mid-level management employees have, how many trainings have been done this past year, fiscal year so far?
This past fiscal year, we haven't had any so far.
Or we haven't had any training at all?
Not this fiscal year, no.
Is there a reason for that?
Well, at the time, we only had one attorney, and she's responsible for not only the caseload, but daily guidance to agencies and assisting me as well. And we made a decision that we'd prep for trainings in the latter part of the fiscal year when we expected to have an assistant attorney general added to our staff. Now that that's the case, we're planning for trainings in the coming months.
And that would assist you in terms of driving on that caseload also?
Well, it would help overall in labor relations, in educating the government's personnel on how to properly implement contracts, communicate with employees, take various actions where necessary. It can help reduce the caseload, avoid cases and whatnot, and improve morale.
And the CBAs that the government is finalizing, how far are we from completing those CBAs?
In finalizing, the ones that are being finalized, one we forwarded for approval, the governor's office, and the other two, we are drafting and I'm reviewing and whatnot.
Okay, so
2 minutes.
Yeah, not too sure. Well, basically, your budget is pretty small.
Yes, it is.
Okay, very well. I see your budget is pretty small. I see you're working, as you said, on onboarding the proper amount of employees to assist you with your caseload, etc. And as you stated, you will be bringing forth training in 2022 for all of your employees, correct?
Can you repeat that last part about training?
Will be onboarding training in 2022 budget for all of your employees?
Training is an ongoing process. When training becomes available, whether through BIT, Division of Personnel, or some of the sources that we use specifically for labor and HR, we sign up and we take advantage.
Okay, very well. Well, I must say, since you have been on board, you have done a pretty good job, and I want to commend you and your team for basically pushing forward in terms of labor relations when it comes to our government employees, and I want to thank you again for your testimony. I really don't have much or any more questions at this point, so again, thank you.
Thank you, Senator.
Mr. Chair, for the
You're
time.
welcome.
Thank you, Senator Blyden. Senator Francis.
Thank you very much, Mr. Chair, and good afternoon to everyone. Chief
Good afternoon.
Negotiator.
Yes, Senator.
Based on your testimony as well, it's been 40 years of existence of the collective bargaining, Office of Collective Bargaining. Do you believe that there is time for us to take a look at the current structure? Do you have any recommendation how 4 decades later, perhaps there is a better way of doing your functions?
A good question. There's always room for improvement, Senator. Specifically, I think we definitely have to take a deep dive and review the various contracts and look at where we can streamline the process. I'd have to think about that some more.
Yeah, I was thinking about just the current structure of the office. I mean, is there an opportunity for us to perhaps restructure and be able to get a greater bang in regards to addressing the issue of negotiation? Any thoughts on that? I mean, you've been to Office of Collective Bargaining before as a legal counsel, and now as the chief negotiator. Any thoughts on how perhaps we could revamp 40 years later?
We can certainly expand. We have a small office, but we have a very large responsibility. We represent most of the central government and some autonomous entities. So there's always room for more staffing. However, we understand the limitations of the budget and we work with what we have. Maybe next time I come for the budget update, I'll have a more specific response to that question.
Very well. I'd love for you to give it some thoughts and maybe look at industry standard, and perhaps we could have a conversation offline in terms of taking a look at that whole structure. What has been the hindrance of you filling the positions in the past? You currently have 5 filled position and 4 filled positions and 5 vacancies. What's the hindrance?
Sometimes a hindrance is interested applicants. For example, last year we were in the process of filling 2 of those positions. We had some challenges in finding candidates for some of them. And then the pandemic hit and we had some people that may have changed their minds, or then some positions were zero funded because they were vacant at the time. It varies sometimes by the position, skill set, and interest.
Okay.
But we've been.
What about salary? I see that the paralegal is in the neighborhood of about $46,000. Do you think that that's sufficient? Are you going to have any good, qualified, long-term candidates to fill that position?
Yes.
2 minutes.
Yes, we actually have a candidate who has accepted the offer and will be starting next month, and he's adequately very qualified.
So how long do you think you're going to be able to keep that person for?
Excuse me?
How long do you think you'll be able to keep that person for at that salary?
Oh, very long. Well, the good thing is these salaries are on the GSP scale, and they will be receiving a salary increase in 2023.
Okay, very well. And have you given any thought to perhaps how government employees could actually receive their increases rather than waiting for several years? Like, for example, perhaps an annual increase, a percentage, whether it's 1-2% on an annual basis based on their anniversary. Automatically they will receive an increase rather than waiting several years, and then you have to find the money and negotiate. You have retroactive wages. Have there been any thoughts surrounding perhaps annual anniversary increase?
Yes, there's been some thoughts on that, but note that some of the contracts do have annual increases built into them. Unfortunately, with the length of time and the amount of contracts to negotiate, sometimes they're not negotiated in a timely fashion. But we have the option of even interim negotiations to address those things.
Very well. Again, you have a small budget. I appreciate your testimony and responses thus far. And again, I'd like to be able to have a discussion with you regarding this current structure and perhaps improving that structure. Thank you very much for your responses. Thank you very much, Mr. Chair, for the time.
Thank you, Senator Francis. Director, in reference to, I'm seeing you have a new position of a financial specialist, but you're ready and you have a vacant position for financial management officer. For such a small entity, why do you need 2 individuals in financials?
Senator, the day-to-day, although the office is small, it has the similar the same day-to-day responsibilities of any office when it pertains to the fiscal aspect and the HR. The financial person handles both fiscal and HR. When it comes to negotiations, those can be very time-consuming. We can be in negotiation for weeks on end with multiple unions, and that person is key to that process throughout. That means that the other responsibilities of the office are severely delayed or put aside altogether for a while. By having more than one, it allows us to continue our day-to-day operations, but also do a broad analysis of the contracts. We have 35 contracts with employees in over 30 agencies, and there are things that we need to constantly...
Repairs and maintenance. Repair and maintenance for the copiers. We have maintenance rental. We have the one contract for the rental on St. Croix. That is currently at $18,000, but we're anticipating getting janitorial services.
I'm making reference to page 2 of 6. Your actual thus far fiscal year 2021 of 162,000. And that is actual as of when? May of what? What's the date for the actuals?
If you're looking at the post audit, I do not have a copy of that report.
What are your actuals for other services?
Other June 2021 is just $33,654.47.
Okay, it was reported to us at 162,000. Not so supplies is 31,000, but other services is 162.
You're asking about actual expenditures. Under other services, for as of June 30th, 2021, $33,654.47.
Okay, so fine. So if that's June, you have July. 1 minute. That means you would have 3 more months. You're not going to spend no more than $40-something thousand. But your projection for next year is 164,000.
We're anticipating expanding our training for 2022.
From 40 to 160 is a 400% increase. I would ask you to justify how are you going to break out what is that $164,000 going for, because in other services we had projected 162,000 and you're only going to spend about 40,000.
We provide that information, Senator.
Okay, I'll come back. Senator DeGraaf.
Okay. Let me get that.
Thank you, Mr. Chair. Good afternoon, colleagues. Good afternoon, testifiers, all of you listening and present. We're going to start with the staff, the unionized staff. Your AGs are exempt?
Yes, Senator.
And you see the Attorney General office assigned them to you, but they're exempt, under exempt status?
Yes, Senator. There will be a conflict for a unionized attorney to work for the Office of Collective Bargaining.
Okay, so how would they get a wage increase?
They get a wage increase if...
Yes.
They'll get a wage increase if there's if there's one approved through the governor.
Oh, okay. I just wanted to, I gotta look out for the, and your GS employee
Personnel fringe and personnel and fringe. It's not necessarily the increase that will be given to the
So now she's helping you and also helping Government House.
She works at Government House and assists us, which one in the
Okay.
same,
Okay. Well, thank you for that, Mr. Duran.
as well as the
year,
staff.
Yes. You had 6 filled positions last year.
Yes.
7.
Yes.
7 at the last budget hearing. A chief negotiator, assistant to the chief negotiator, administrative secretary 1, 2 of those positions, a labor relations specialist 2, a labor relations specialist, and a paralegal. This year you're down to 5. How many terminations, resignation, or retirement have you had in the last year?
We've had two separations from the office.
Okay. That's like 33% of the office separated. That's a high number for such a small.
Well, it would be high for a small number, yes.
And you believe that you can fill these 5 vacant positions?
Yes, we currently have the paralegal officer will start next month. The financial management officer will also start next month. The coordinator of administrative services, that their information is being processed at this time. And we just received the NOPA for the admin secretary on St. Thomas, so we will advertise that. And we'll also advertise the financial specialist. Well, it's what we're requesting in this budget, but we were also looking at the fact that we currently have some funding that we may be able to, if possible, begin by using the funding that we have currently to fill it before the fiscal year begins.
Okay. So, Ms. Duran, for supplies, you're saying how much? 30-something? Because I see you have 31 here. You have already spent. The post-audit report is saying that you have already spent 31.
Yes, the post-audit report is saying for 2021 is saying actual, but that's actually the appropriation for the entire year.
Okay.
And not what we actually spend year to date or until June 30th.
Okay. Okay. Good explanation. So what is the actual for supplies?
I'm sorry. The actual is 4,880.25
You got a lot of money left
as
there.
of June 30th.
Okay, so I mean you have 26,000 left there. And then you said the actual for other services was 33,000, so you have $130,000 left.
We have some things that we are currently acquiring, but yes, we have a large amount right.
So is there a need for $164,000 in that category next budget cycle?
Yes, Senator, as I just explained, we're increasing staff and considering. I'm very mindful of our climate and our hurricane season, as well as the current pandemic. So having to work remotely where necessary requires additional equipment if we have to, say, go remotely fully again.
Okay.
So I try to, anticipate those things and have the additional resources where necessary.
Okay. We had Bureau of Motor Vehicles before us, I think it was this week. And looking at their pay scale, they're one of the lowest in government, them along with agriculture and park and recreation. But what's the status of the contract for those ladies that work in a revenue generating office?
Most of them would be in the BMV, would be under USW Masters. We are currently in negotiations with for that contract.
Okay. You expect to conclude that before the end of this fiscal year?
Yes, I expect. I'm optimistic, but I'm only one party to the negotiation.
Okay. Because it would be, they also have, I spoke to some of the ladies on there, and they have also a high turnover rate because, you're making 28, 29,000. As soon as something else come up, they're going to leave. So we need to be able to begin to equalize those areas so that we can really have those revenue generating entities, be able to have stable staff. We're still 3-4 days behind with registration, with licensure, so we need to get that staffed up. So I'm hoping that that contract can be concluded before we do the budget markup so that we can include that in the budget.
We're working as quickly as we can, Senator.
Okay. Senator Sarro. Oh, wait, it's back. Senator Carrion.
Chief Negotiator.
Good afternoon, Senator Carrion.
How are you this afternoon?
I'm wonderful. And yourself?
Good, good. I have a few questions for you, and please excuse me if one of these have been asked. I just came out of a meeting I had quickly. So you are requesting an increase of the 57% of your overall budget, and you're here today to justify and present the reasons why. What were some of your shortcomings and obstacles in the prior years?
I think the shortcoming would be, the ability to fill vacant positions, to move in a more efficient manner through negotiations and basically the operations of the office. I mean, the pandemic had a serious effect, but also the limited staffing affected it as well. But we did the best we could, and we continue to augment as we can. Just know, for Senator, over the years, the budget has been as high as about 900,000. So around where we're requesting right now, when we went down slightly here and there when there were budget cuts of positions that remained vacant for a long period of time that was zero funded. But this is a reasonable amount considering our awesome duties that we have to carry out.
Got you. And when you mentioned that the operating and the efficiency of the office, other than the pandemic, has been affected by short staff, right? You've been short staff.
Yes, Senator.
The post audit says that you have 5 vacancies currently. Is that still the case?
Well, yes, but they're in the process of being filled. We have 2 employees joining us next month. We have 1 other vacancy that will be filled, and then we'll have 2 positions that we need to advertise. One of those positions became vacant in May of this year. So, as you know, the NOPA process requires that individual to be out of the system, so to speak, before we can fill that position. We recently got approval of that NOPA, so then we can advertise for that position.
Any new positions you plan to incorporate within FY22 budget?
Can you repeat your question?
Any new positions you are planning to, or you have incorporated in FY22 budget?
Yes, Senator. 1.
And you feel confident that with these new positions and filling the vacant one, you should be able to function more efficiently?
Absolutely.
So there's a number of cases that you have, I think, is around almost 300, right? 270 something?
Yes.
But I know they're at different stages. What do you foresee being able to conclude and finish off in FY21 and even in FY22?
2 minutes.
What are those numbers looking like?
And can you repeat, what do I foresee?
Closing off in those negotiations for FY21, and are you estimating closing off in FY22 a specific amount? What is your target goal?
In terms of negotiations or cases? You initially asked about cases. In terms of negotiations, I'm optimistic that I'll be able to complete the remaining 5 that are currently pending. I anticipate being able to complete those. Note that some contracts currently have wage reopeners, even though they're current. Is possible. I won't make any promises. Again, I'm one party to the negotiations, but I'm optimistic. I haven't done a full review of what I can do for fiscal year 2022, but I have been in general discussions with unions as to what we anticipate we'll be focusing on, and some of them that had to be rescheduled, that were tentatively scheduled and rescheduled, we will revisit those and put them back on the calendar. As you know, I'm before you again for the budget update. Maybe by then I'll have a clearer picture on that.
Okay, well, I look forward to that. Now, in the post-audit report, I didn't see you have anything included for supplies. I mean, you have included, but what I mean, the amount hasn't changed.
Right, the amount hasn't changed, but it should be sufficient.
Okay. Even with
Time.
more staff coming on board.
Yes, but if we're not, we'll contact you.
All right, and other services and charges for FY22. I know for FY21 you had close to around 30,000, but there's no breakdown in the post-audit report. What are some of those other charges and services?
Other charges and
Other services and charges.
other services includes things such as IT, telecommunications, rent and service agreements, say with Xerox and our, as well as training that we conduct or that we attend. That's
Can you provide to this committee through the chair a breakdown of other services and charges? And I guess that there you have included some professional services also that your office receives, so we could know who you have a contract with, how long is the contract, term of the contract, but if it ends in FY21 or if it continues, and what's the amount for that contract for?
okay. Yes, Senator.
Also, in your testimony, I think we spoke about the negotiations that you have, but regards to the cases, what's your status regards to that?
Time.
The cases are at various stages. Note that there are about 10 different types of cases. Some are handled by the local and federal courts. Those are the civil cases. Some are handled by the PERB, and some are arbitrated or otherwise resolved. So the status will vary by the case. Yes.
I guess my question was, do you, from your experience, what's the average amount of cases a year that your office processes and handles to completion?
The average number, I can't say. I know for the year so far, for last year was around 52. I can't recall the number for the previous year, but yeah, I do not have that number.
All right. Mr. Chair, thank you.
Thank you, Senator Carrion. Senator James?
Good afternoon to the people of the Virgin Islands. Good afternoon, testifier.
Good afternoon.
I'm just happy to hear about the progress when it comes to several of our completed negotiations within the offices of collective bargaining and the current negotiations. But you made mention in your testimony in the section that speaks to pending cases that the Office of Collective Bargaining remain committed to resolving pending cases and avoiding future ones. Enlighten me a little bit. How would you go about avoiding future ones? What is the strategy? Is it because you're going to have the necessary personnel on board? Can you explain to me what you mean by that?
When I say avoiding future ones, key is ensuring that we maintain good labor relations. We also comply with collective bargaining agreements. And so in order to do so, we conduct trainings for our clients to educate them on labor relations, discipline and discharge, documentation, proper implementation of contracts and whatnot. Some of our cases may involve violations to certain terms of the CBA. So by going through these, having these trainings, it ensures that our clients are adequately prepared and educated on how they're supposed to apply the contracts, handle various personnel matters, HR matters, labor relation matters within their agencies. So that's why I say avoid future ones.
Well, I love your futuristic way of thinking, But if you can just enlighten me, when it comes to the training, does it come with a cost? Is it done in-house? Because I don't see anywhere in the budget that speaks to the cost for training. How does that training is carried out?
We, the employees at OCB, conduct trainings for the various levels of management. For example, we generally will have an annual senior management training where all of the upper level management, commissioners, directors will conduct trainings on a variety of topics over maybe 2 days. We started having trainings with middle management on areas that they focus on and what we see in cases. And this is at no cost, yes. We conduct it, we provide the material, we administer the training. In some instances, some agencies will ask us to come in and have a training during their retreat or their senior management conferences and on specific topics. And I would also do one-on-one with commissioners.
You do create like manuals or blueprints?
Can you repeat your question?
2 minutes.
With this kind of training that you have, and when it comes to succession planning, that you create some form of blueprint or manual, so when there's some transition in personnel or individuals retire or leave, that institutional knowledge stays there.
Yes, we do our best, and we monitor our clients in terms of new leadership and whatnot. If we know a new commissioner has come on board, a new HR director, we take the step and contact them, provide them with information, provide them with our contact information, and let them know that we serve as their labor relations and HR arm external to their department staff.
And last but not least, you mentioned the 3 words, the labor relations officer, several times, and I know that that is one of the positions that are vacant. I know you referenced the financial management officer, the paralegal officer, the coordinator for administrative services, the administrative secretary too for St. Thomas, but I haven't heard you touch anything on the labor relations officer. Can you speak to what is the strategy to get that up and running so you can avoid future cases and be able to have that smooth transition and agreements with your clients?
Well, the labor relations specialists are the ones that focus on the caseload and work with the attorneys directly on those. The labor relation officer is an exempt position within the budget. It's currently vacant, but that would also be advertised.
Okay, it's a straightforward budget, so I don't really have much to say. I think most of the questions were asked. I hope that you get what you're asking for as far as filling those vacancies, and I wish you the best in your endeavors as you fight for the people of the U.S. Virgin Islands. Thank you, Mr. Chair, for the time.
Thank you, Senator.
Thank you, Senator James. Senator Sarah?
Thank you, Mr. Chair. So you're looking for another admin attorney, Springett. Is it one for each island you're looking for? You already have one now.
Yes, we have one on St. Croix currently. We will be advertising the vacant position on St. Thomas.
Anything for St. John?
No, we do not have an office on St. John.
Have you had to go to St. John though for work?
No.
Fringe. Your fringe is roughly at 46%, 47%. And I'm seeing a trend with agencies that come before the body. You have a good number. Some are at 50, some are at 52%. Have you been able to, on the healthcare side, a married couple, the husband may work in a different agency, he's paying for the family insurance, therefore that wouldn't come out of your budget. Are you able to scrub those numbers or quantify what it looks like, or we just going with a bare 46%? But that kind of inflates the budget at the end of the budget cycle.
No, I have not done that type of analysis, Senator. I know that generally we, as a government, see a slight increase in fringe, particularly to health insurance, because that does increase generally annually.
But we've been taking.
Yes, you have. Yes,
we have
the Senate has
insurance. Good. Just giving us a little bit of props here.
Yes, the Senate has been providing the additional funding when the health insurance has increased, and I have made it clear to many unions that although the insurance is going up, the employees have not had to absorb it for many years.
Yeah, okay, and we plan to do the same again.
Thank you very much.
Let me go to the Assistant Attorney Generals. Are you
Okay.
in a union?
No, we're not. We're exempt employees.
Are you, Sim, you speaking for both?
Correct. We are
Speak
both.
say your name first.
So I have a little issue. When I looked at the Department of Justice budget, we're bringing in special investigators, making like 85,000, and you still have assistant attorney generals at 78,000. The attorney general's argument to me was that they were unionized and they were going to the table to negotiate with you, correct?
Okay.
Now, it didn't sit well with me, the argument presented by Justice. So I'm going to read the Virgin Islands Code, subsection 113.
Okay.
And I'm so happy these two legal minds are here. We have three attorneys here talking to us. So I'm going to read this and you tell me your interpretation. There shall be in the department such assistant attorneys general as the governor deems necessary for the proper administration of the department. The assistant attorneys general shall be appointed by the governor and shall hold office during the continuance in office of the governor by whom they are appointed and until their successor are appointed and qualified unless sooner removed by the governor.
2 minutes.
Any assistant attorneys general appointed under this section shall perform such duties as the attorney general prescribes. If you are appointed by the governor for his duration, how do you become unionized?
Through Act 4440.
Tell me. Explain that. I can't pull up now.
Act 4440 can be found in Title 24, Chapter 14 of the VI Code.
Okay.
It provides various things, but just generally, I don't have it in front of me as well. It provides that the government and labor representatives can negotiate for public employees. And there are definitions of various terms such as public employees.
So having them unionized is okay. Educate me.
My attorneys are exempt.
I know you're attorneys, so I'm just talking about because they're going back to the table with you. And it presents that it's like Kokobe and Tapayas in local terms, where we're hiring special agents, making more, assistant attorney generals. And in my head, I'm trying to figure out, there's a process of, negotiating, blah, blah, blah. But if they were exempt, we'll be able to just make some adjustments in an easier fashion. Excuse my ignorance. I am nowhere the collective bargaining expert.
Well, I can't make a decision in terms of how special agents are hired and whatnot.
I know
what
that.
I do know is that these individuals have various levels of education and experience, and in the AG's defense, there are salaries that were set prior to her time.
Yes.
And they don't go down, right? They go up, and some may have been set in one area, but of course, these are the examples of why our office needs to have financial professionals to do this type of analysis and look at, we generally look at, yes, we look at national standards, we look at things like cost of living, but we also need to look at where we have various positions. The AG's office has attorneys, support staffs, agents, various things.
Yeah, I was just, for me, it wasn't, questioning the judgment. It was how do we move that professional level staff when you need to make adjustments without having all the red tape and then coming back to you and then sometimes these negotiations take a while.
Time.
With your indulgence, Mr. Chair. These negotiations end up taking a while, and then by the time you get them on step and everything, it's a cost of the government, and so it was really a question of processes, if
I,
may.
I understand. Well, some of the processes are legislated, and so with your help, but also in order to increase salaries, we have to have the funding. I understand the process is tedious. I'm currently negotiating about 7 contracts all around the same time. Thanks to the virtual world, we're able to do that, and they're all moving close to completion at the same time, and it's a tedious process. And I know that today I could think that today is the last day of negotiations, and then
something else come up.
We work on it, but we do not complete it. So everyone needs staffing right now. Everyone is losing employees. Everyone needs nurses, doctors, lawyers, teachers, everyone. But we have to do them in an orderly process. The saying, haste make waste. So we do our best with what we have, but I understand how long it takes. The employees come to me, the employees approach me and say, when is this going to be finished? I can't say the end of this month. I can't guarantee that. I just move at the pace as quickly as I can.
What's the Act number? 44?
Act 4440, but the chapter is Title 24, Chapter 14. You could just look up Chapter 14 of Title 24. That provides the breadth covering 377 is for OCB, but it covers the PERBs processes, what rights employees have, what rights management has, and the right to negotiate contracts and negotiate various terms and conditions of employment.
Thank you. Thank you, Mr. Chair.
Thank you. I think the overall question was whether or not it really makes sense for the attorneys under the Attorney General office to be in a union, because that is the reason why those salaries are stagnated right now, because you're waiting for the union negotiation to conclude. While if they were not in a union, like the 2 attorneys here, you would have more flexibility to make sure that those individuals are paid at a certain level that would be able to aid in retention of those employees.
Right, I understand the question.
And I mean, we look at, to me, we're tying our hands, because when they're in a union and they're assigned to the criminal division, if I want to reassign an attorney and assign them to OCB, the attorney can't be in a union, so they got to drop the union affiliation. So if all of the attorneys are not in a union, it gives you so much more flexibility. And according to the next part of the code, the next part was more saying that attorneys representing the government of the Virgin Islands should not necessarily be unionized. They do need a process in terms of contract negotiation, but we're just questioning that particular part. And the special agents were ranging from like 65 to 85,000, and we had some attorneys who were presently working, who were making 71,000. And we know that in order to be an attorney, you have to have a Juris Doctorate, and in order to work for the AG office, I would imagine you have to pass the bar.
Correct, sir.
So there's a high threshold of what you need to meet versus the threshold for somebody who's coming in as a special agent. And when we ask, well, what's the qualification for a special agent, in some cases it's not even that you must have a degree. So you could come in as a special agent and make 75,000 based on this and that experience, while that degree Juris Doctorate person is stuck at that 71. But we're just trying to see how we could come up with a mechanism to be able to deal with that, because we increase the budget for public defender and all those other entities to get attorney salaries up to par, because it's been like a revolving door. And in the AG office, it's still a revolving door. We hire 4 attorneys, we lose 2. So we're losing attorneys on a regular basis. So is it salary, or is it other factors? And perhaps at a certain point, it was a good idea to have them unionized, because that was a way for them to go up. But at this point, it is no longer in their best interest. And I think the special agents were not unionized. So the special agent, you go pay them whatever you see fit. They were going in like, they are not unionized, so you have flexibility. You go pay them X amount. And then my biggest pet peeve is just we're seeing exempt positions that I don't know how some of them became exempt, because they're not policy per se, but we've seen exempt positions that are just, and not in this administration alone, throughout all administrations. So it's not pertinent to just this administration. But just positions that are made up. There's barely any qualification. You give that person $75,000, you give them $85,000. They barely have any responsibility, just made up. And then you have our people who go away and get educated, and they're stuck. And something really wrong with that. I'm like, wow, you know, I'm seeing some individuals, barely a high school diploma, no responsibility, and a made-up position. And they're making good money, and then you have those that have student loans out the wigwam, and they saw, and I'm like, what kind of system have we created when you have a whole level of managers? And it creates issue for you, because we have teachers with master's degree starting salary at 40-something thousand, and somebody a high school diploma making 75,000 and don't have any responsibility. It's just a made-up position. You know, I mean, a deputy commissioner for HR, but you have an HR director. So we know that, okay, these are just, we just padding the budget, and that's one of the reasons that we have that makes your job hard, because when we pad the budget with other positions, then we decrease the amount of money and flexibility you have to pay employees who are really doing what they're supposed to do. I just wanted to put that on the record. Senator Saru, and then we'll let the good budget director conclude.
Point of information, Mr. Chair. Right there,
point of information, you go ahead first. Wait, sir.
Thank you. I just wanted to make a point of information right there where you were discussing the fact that some assistant attorney generals were unionized and some were in the union. And for a matter of fact, the union have been lobbying to try to get those additional attorneys unionized, because what you were having was the same revolving door impact that you spoke about, consequential to the fact that these individuals that were non-unionized was operating at the pleasure of the governor. So a lot of times what you were seeing was that we had assistant attorney generals that were being terminated, you know, and question the rationale or reason behind of the termination, because it wasn't for cause, but just because, again, they function at the discretion of the governor. So I know in the 32nd legislature and into the 33rd, we had a measure to address that particular issue. Now I'm suggesting that perhaps we need a deep dive discussion with all the stakeholders so that we could be able to address that issue when you look at you know, continuance of government and these individuals, rather than having their continued spiraling downwards or the easily turn around of attorney generals over and over, assistant attorney generals over and over again.
Thank you, Senator Francis, for your point. And going back to, well, DOJ really concerned me, and not in a way as questioning the leadership, but the structure that we've created. Because I asked the question because, for instance, we had an exempt position that was created randomly, 75,000 employee, just a high school diploma, and a random created position, and making $3,000 less than the unionized assistant AG. So the question would be, what qualifies the attorney to end up in a union? Like, what's the litmus test? What's the criteria? Is it by choice? How does that look?
Well, Senator, so let me take you back to where it begins. The unions make petitions to the PERB to be certified to represent certain employees. And the PERB makes a determination through the chapter that I referenced in Title 24, Chapter 14, and their PERB rules and regs that they make a determination based on different factors and provide a certification to the union to represent the assistant attorneys general. I think it's a very clear conflict to have the ones in OCB unionized, so they're not. And of course, the union is free to seek further certifications or a unit clarification to represent other attorneys. So it's a process that they go through, and the PERB makes that decision.
Thank you for that.
And note it's the position that is represented by the union, right?
Got it. Thank you for the education, because I've been thinking about these attorney generals, and I'm like, you pass the bar, you have student loans, 78K, you stuck there, somebody coming in, making more than you, made up positions, and we've created a system that's really detrimental, and, it kills employee morale, and we create the other unintended consequences from that. Senators Francis and Carry On, you have any further questions before we wrap up? Okay, Carry On. I can't see you. Senator Francis, wave yes or no for him. Second, no. No? Okay, good. You may proceed at this time with the closing remarks.
Thank you, Senators, for your time and attention today, and the opportunity to defend our budget of $1,199,480. As usual, each agency comes before you to testify and defend their budget. Considering our unique role, I not only make the request that you approve our budget, but also the budget of the other agencies. I provided a thorough explanation of the reasons for the increase in our budget. We describe ourselves as a small but mighty team, but we need additional support in order to carry out the mandate of the office. The agencies that we represent also need the necessary funding to carry out their mandates, but in order that my negotiations, our negotiations at OCB, are then actually implemented, because everything that we do relies on the funding that this body provides. We negotiate for active employees, but these salaries are what these employees consider when it's time for retirement or separation or moving on to somewhere else. So while our work is based on the employees that exist in government, these employees can be at various stages of their career, and at any given time may be considering, should I retire? So the question is, will they have a retirement? A number of employees are now leaving government after 9 years of service to avoid being vested because of the concerns that the GRS faces at this time. And they've been appealing to the legislative branch and the executive branch to take action. So in approving our budget, in approving the executive budget as a whole, I want this body and the Senate as a whole to be mindful of the far-reaching effects not only of the salaries that we negotiate for current employees, but the effect that that will have on these employees' future retirement and the economy as a whole. We have employees that are concerned, should I retire now and possibly only receive a pension for a few years, or should I stay at work when I could possibly retire and give someone else an opportunity? And so I thank you again today for the opportunity, but in considering OCB's budget, please also consider the budget of our clients, as well as the future of this territory as it pertains to active and retired employees. Thank you. And again, I always show gratitude to my employees, so I thank those that are present, Ms. Durant and her staff, and the rest of the OCB team that's watching. Thank you.
Thank you for your closing remarks. And GRS is a priority for us, as we've been meeting feverishly to work on some cash infusions, reforms to the system. What's not, all of us are impacted by the retirement system. Millennials like me, paying into the system, you don't know if you'll receive funding. And of course, we all have retired parents that we want to have a good quality of life. So either way, we all live it with the primary resources. So thank you for your care and your concern today and your testimony. Thank you to my colleagues. Thank you to central staff, to security, to media, to the clerks, to our stenographers, and everyone else that make our meetings possible. The Committee of Finance on July 23rd, 2021 is hereby adjourned.